2 years ago, the governor and the Executive Office of Health and Human Services and the Office of the Health Insurance Commissioner, I am Marie Ganim, the Health Insurance Commissioner, we got together and we announced a partnership with Brown University School of Public Health and with the Peterson Center on Healthcare to slow the pace of healthcare cost growth for Rhode Islanders. We have been supported in this effort by Bailit Health, and you'll be hearing more from them as this program goes forward. The Rhode Island Cost Trends Project was created with 3 aims: to reduce the growth in healthcare costs by developing a cost growth target and providing transparent healthcare performance data to influence purchasing decisions and care delivery reforms. Number 2, to develop a deeper understanding of the state's healthcare cost drivers and cost variations. And number 3, to create a sustainability plan to support ongoing analysis so that the state always has this data to judge how we're doing relative to spending on healthcare. To accomplish these goals, we formed the Cost Trend Steering Committee. It is a group that's comprised of leadership and representatives from state insurers, from providers, from businesses, and community organizations. And I really want to take a moment to thank all of you who are on the steering committee for volunteering your time into this effort and your expertise. And many of them are on panels today and will be speaking. The steering committee has been led by 3 co-chairs: Kim Keck, who is the CEO of Blue Cross Blue Shield of Rhode Island, and Dr. Al Kurose, who is the CEO of Coastal Medical Providers, and myself representing the state as the Health Insurance Commissioner. The steering committee developed a methodology for setting a cost growth target for Rhode Island. We looked at different alternatives and decided that a cost growth target would be the per annum rate of growth benchmark for healthcare costs in our state. We set the target at 3.2%, which is equal to the state's long-term economic growth rate. In other words, we felt that it was important that health spending in our state not exceed spending on other goods and services. We know that that's an ambitious goal, but that's the benchmark that we set for ourselves. This target is just that, it's a target, it's voluntary. It is not written in state law that we will definitely penalize folks who don't meet it, but instead that we're coming together to try to curb costs and spending. The target became effective in 2019, and it will be 3.2% through 2022. The steering committee members signed an agreement, we called it a compact, to formalize the target. And then it was subsequently codified by the governor in an executive order in early 2019. That executive order also directed state agencies who have a hand in healthcare spending to also comply and support moving toward this goal. So certainly we can look at the Medicaid program as a very important partner in this work. Someone might ask, why should Rhode Island maintain a cost growth target during a time of such illness and economic upheaval? The steering committee has affirmed that our Rhode Island cost growth target is needed now more than ever. Struggling employers and consumers can't afford large increases in health spending at a time of economic hardship and state tax revenues taking a sharp decrease. Finally, cost growth is especially hurtful to low income and communities of color, and they have been hardest hit by this COVID-19 pandemic. So we feel even more invigorated now to support using data to set policy that can curb the growth in our healthcare spending in our state. So today we come together for a discussion of 3 important topics. First, trends in Rhode Island healthcare cost growth. We have good data now. We can actually present it to you all for your understanding and for your input. We have experience with care delivery on COVID-19 that we have a great panel that is going to share how practice has changed due to the pandemic. And thirdly, how to address rising pharmacy costs. So when you see the overall data, you'll understand why we've decided to begin our policy discussion on the area of pharmacy costs. And we're actually very grateful. We have a representative of CVS who's been participating in our steering committee, and he will be on the panel that'll be discussing this issue. And then a quick reminder to the steering committee, we have a meeting on Monday to formulate recommendations for action. So I just want to make sure people are willing to put in a little bit more time on Monday for our steering committee meeting. We'll begin today with a presentation by Megan Burns of Bailit Health. Megan will share with you the results of our baseline analysis of per capita spending growth between 2017 and 2018. Over the past year, we've done a test run of collecting the data from insurers to calculate performance against the 3.2% target. We're looking at this the prior to the 2019 target kicking in. Just gives us a test run to make certain that we know how to get the data, we know how to analyze the data, and we know what problems we may be facing going forward. So thank you to all of you on the insurer side who've submitted the initial data that we've been able to look for and to look at the trends and to compare against performance. So we can look before we implemented the target, we'll be able to look after we implemented the target. We will annually be holding public meetings like this one. This is our second one, actually. We did have one last year. We'll be reporting at the annual meetings on how we do toward the 3.2% goal. And also we'll be hopefully getting your input about what we can be doing about what's going on, both regarding overall cost growth and what are the drivers of the cost growth. We anticipate in reporting 2019 performance early in 2021. Secondly, we'll explore how the COVID-19 pandemic has impacted the healthcare delivery system. And Professor Betty Rambur, who is an esteemed professor of nursing at the University of Rhode Island, will moderate a distinguished panel of Rhode Island providers to discuss how care delivery has changed over the past almost 8 months. Just feels like 18 months. And to explore the possible post-pandemic implications for care delivery. Third, we'll have a review of the analysis that's being conducted by Brown University. Brown has been our partners every step of the way in this project. They actually have been using our all-payer claims database, our APCD information, so that they are looking across the board at healthcare spending and analyzing it to give us the transparency that we're looking for. The purpose of these deep dive analysis is to pinpoint opportunities to reduce healthcare spending through action at the state, the market, the insurer, and or the provider level. Today, Dr. Ira Wilson, who represents both the School of Public Health and the medical school from Brown University, will share his pharmacy cost analysis, and his presentation will be followed by a presentation on two strategies on managing pharmacy costs by Trish Riley. Trish is the executive director of the National Academy of State Health Policy. And then we'll have a panel discussion on cost strategies relative to pharmaceutical costs, moderated by Dr. Peter Hollmann. Thank you all for this, for devoting your time to this conversation. And then I just want to close by thanking the Peterson Center on Healthcare, which has provided support for this project. I can honestly say we would not be doing this work without the support of Peterson, and we are forever grateful for their contributions, for their partnership, for their collaboration all along the way. The Peterson Center on Healthcare was established by the Peter G. Peterson Foundation to transform U.S. healthcare into a high-performance system by finding innovative solutions that improve quality and lower costs, and accelerating their adoption on a national scale. Without the center's support, we wouldn't all be here today to discover and to discuss this essential work. So thank you so much. Now I'd like to invite Megan Burns, a senior consultant with Bailit Health, to present the findings from our baseline analysis of performance against the cost growth target. Thank you so much, Megan. I'll turn it over to you.
Thank you, Commissioner. I appreciate the introduction, and hello, everybody. Today, I am going to just move this little box here in one moment. I am going to be presenting to you the cost growth target baseline performance. And as the Commissioner mentioned, Bailit Health led the analysis of the cost growth trend of healthcare spending between 2017 and 2018. And that is informing the cost growth target program and the analysis that will be performed for the first year of performance, which is 2019. So I'll review these findings with you, and my colleague Michael will be monitoring any questions that you may have. You can type your questions in the Q&A function, and we would invite you to have a discussion today. So if you have any questions or comments, please feel free to chat them, and Michael will help facilitate that as well. By way of background, the commissioner mentioned this, but I'm going to review it in a little bit more detail. The Cost Trend Steering Committee established an annual cost growth target of 3.2%, and this is measured on a per capita basis. And this is in effect for the 4 years of 2019 through 2022. We have collected some data earlier in the spring on the 2017 and 2018 performance, and just recently, all of the payers have submitted some data for finalizing the 2018 data and 2019, and we'll report those in a few months. In order to perform the calculation of the per capita cost trend for the year preceding the cost growth target, the 4 insurers that we asked were Blue Cross Blue Shield of Rhode Island, NHP, Tufts, and United, to submit some spending data for all lines of business. That's Medicaid, Medicare, and commercial. I want to personally thank all of the participating insurers for their continued engagement with us on the data submission process and the ongoing validation process, both from last year's data and ongoing today in this year's data submission process. So thank you. In addition to the 4 largest insurers, we also gathered data from CMS, the Centers for Medicare and Medicaid Services, on their traditional Medicare spending, as well as from Rhode Island Medicaid. Finally, I just want to note that in the data that were submitted, payers were asked to follow specifications so that we could have some reasonable consistency in spending calculations across the payers. And we developed a specification outline that is published on OHIC's website and is largely based on a specification that was used in Massachusetts, which is the first state to have a similar cost growth target program. So when we collected this data, we were collecting summarized data from the plans. And so it was very important to do a validation. And I want to explain what the validation was so that you can use that information to put the data that I'm going to show with you in context. So the first thing we did was just ensure there was a basic completeness check. That was all of the data that we expected to be submitted, indeed submitted. And then second, we did a reasonableness check. And this is where we performed an analysis of the data that we received against publicly available benchmarks and other data. So for example, we looked at the trend that was submitted as part of this data against rate review information that's submitted to OHIC. And while we recognize there is some ongoing variability between different data sources, it helped the project staff ask the payers the questions so that we could have some reasonable guarantee that the specifications were followed in the same manner across the plans. Following our initial validation process, we worked with the insurers, and oftentimes we ended up getting some new data as we all began the practice, as the commissioner had mentioned, in submitting this data and understanding the specifications. We also performed a calculation of the net cost of private health insurance, which I'll define and explain in a little bit. And we used publicly available data sources for that information and reviewed those findings with the payers. And then finally, staff at Gorman Actuarial, who also provides support to OHIC, provided a peer review of our results. So there are 3 notes of caution that I want to make clear before we dive into the data. The first thing is the data that we received was based on summarized data from the payers. This is not the same as data that comes from an all-payer claims database. And there are reasons why data that come from the all-payer claims database can't be compared to the total medical expense. And I want to just note that the presentation that Dr. Ira Wilson will be presenting later in this presentation will be from the APCD. And there's a couple of reasons why, and I want to mention those. And I have to say, I am so sorry, but I cannot figure out why my animation is moving quicker than I'm moving. So I apologize for going back and forth. A couple of reasons why are we collected information on non-claims payments. These payments are payments that may have been made from a plan to a provider for an incentive, for example, or perhaps care management support. Those sorts of payments are not collected in the all-payer claims database. The second reason is we asked the commercial insurers to submit information on their self-insured population. While the APCD in Rhode Island has some data on the self-insured population, it does not contain all of the data. And then finally, the data that I'm presenting to you today is net of pharmacy rebates, and the APCD does not collect pharmacy rebates. The other thing I wanted to mention in terms of notes of caution is that the baseline performance results cannot be compared to other publicly available measurements. That's really because there are different data specifications. And so we just need to be mindful of what the specifications and the methodology on the data are before we compare them. So for example, if you see spending on Rhode Island spending from Kaiser Family Foundation, for example, we hope that the trend is similar to the data I'm going to share with you today, but there are reasons why it may not be. And then the final note I want to make is that the payer data submissions were validated, as I mentioned, but they were not audited. So we can't be sure that all the payers perform the calculations in the manner that we have prescribed, but the validation process and the conversations that we have had help ensure that there is some reasonable consistency across each of the payers. Okay. The other thing I wanted to mention is that as we're talking about the APCD and the data that we collected from the payers for the purposes of measuring against the cost growth target, is that we do have 2 different sources of data, and they serve different purposes that are very important to be viewed at in concert with each other. So the first one, as I mentioned, is this payer reported aggregate data. This is the data I'll be presenting to you shortly. The primary purpose of this data is to assess performance against the cost growth target. The second type of data is the data that come from the APCD, the All Payer Claims Database. And the primary purpose of this is to identify underlying cost and cost growth drivers that help the state to inform why the state, the market, payers, or provider entities may or may not have met the benchmark. And the information that Dr. Ira Wilson will be presenting later in today's presentation is an example of the APCD analyzed data. Before I dive into the data, I want to share with you 3 key definitions. The first is total medical expense. The data that you'll be seeing represents all spending incurred by Rhode Island residents for the healthcare services by all payers reporting into OHIC. This information is reported net of pharmacy rebates. The second is the net cost of private health insurance. This is intended to measure the cost to Rhode Island residents associated with administering private health insurance. And by that, I mean commercial insurance, Medicare managed care or Medicare Advantage, and Medicaid managed care plans. It's defined as the difference between health premiums earned and claims paid. And as I mentioned earlier, those data come from publicly available sources. The final definition is total healthcare expenditures. This is simply the sum of total medical expense plus the net cost of private health insurance. And as I mentioned, this is reported net of pharmacy rebates. Okay, my PowerPoint is itching to get you this data, and so we're gonna go for it. So on the left-hand side of the screen, you see the first cut of data. This is total healthcare expenditures. Again, that total medical expense plus the net cost of private health insurance presented at the state level. This is the aggregate total trend, and it's broken down by the major markets. So for example, commercial, Medicaid, and Medicare. And on the left-hand side, I just want to be clear, is the aggregate annual trend. So that's the total number of dollars and the change between the 2 years. On the right-hand side, this is what is essentially will be how the state measures their performance against the cost growth target. This is on a per capita basis. So this tells us whether the state is spending more on a per person basis than it did on a previous year. In the case here between 2017 and 2018, in the data that we collected, we see that there was a 4.4% per capita annual trend. I just want to remind you, this data is net of pharmacy rebates, with the exception of Medicare fee-for-service, because we were unable to collect that data. So there might be some slightly overstated spending with respect to Medicare. So when we drill down from the state level and the broad market level, we can look at total medical expense. Now, this is just spending on healthcare services, both claims and non-claims. This is not including the net cost of private health insurance. And we can look at it in terms of the individual markets, meaning Medicaid fee-for-service, Medicaid MCO, similar for Medicare as well as commercial. Again, on the left-hand side, you see the aggregate annual trend, and you'll see here on an aggregate basis, the commercial had the lowest trend, where Medicaid MCO had the highest trend. On the other hand, when you look at the right-hand side, which is the per capita annual trend, again, what that benchmark will be, what that target will be measuring, commercial trend was 3.4%, and the Medicaid trend was 5.8%. I just want to note, we are unable to report Medicare at this higher level market due to the limitations in the way CMS supplies data for this effort. Drilling down a little bit further, we can get into service category trends. So this is at the state level. Each of the payers was requested to submit their spending data, both in aggregate, but also by service line. We provided to them definitions on, for example, what hospital inpatient and outpatient meant, what professional physician, long-term care, or non-claims meant. And so what you, the table on the left-hand side shows the trend in total dollars of each of the service categories. And on an aggregate basis, you can see the fastest growing service category was pharmacy. Again, this is reported net of rebates, and the slowest was long-term care. Dr. Ira Wilson will be providing some more information on pharmacy, specifically breaking out the 3 different Medicaid, Medicare, and commercial markets, and sharing with you some more information. And while the information that he will present is generally aligned, it's not exactly the same, and that is because of the data limitations and the differences in the data sources that I wanted to mention, but they're not inconsistent. So we can take the next level of drill down and look at the annual growth in commercial total medical expense by service category. I want to call out a few things here. First, there was an increase in outpatient hospital spending, which represents about 1/4 of all spending in the commercial line of business, and a decrease in inpatient hospital spending, which was just about 20% of all spending. In a few slides, I'll share with you a side-by-side analysis on hospital spending across the 3 markets. And I'm telling you, this PowerPoint really wants me to speak quicker, but I think for the purposes of what we're doing, I'm going to go a little bit slower if I can get myself back. I'm sorry about that, folks. Thank you for bearing with me. The last thing I wanted to note on the commercial total medical expense by service category is physician services. So here you see both primary care and specialty care. They were split out. We asked specifically for some more information on primary care spending versus specialty care spending. In total, it accounted for about 22% of all spending, and it had a relatively low trend at 2%. Okay, here we have Medicare, and there's a couple of things that I'd like to note here. As I mentioned earlier, we had some limitations in the data that we received from CMS, and so we had to do some estimating here. I want to note that retail pharmacy increased by 12% and represents about a quarter of total Medicare spending. And while representing a really small piece of Medicare spending, which is non-claims, the spending here grew by 23%. Now, I recognize that's relatively small, but I think it's consistent with what we know, and that is the increase in spending was largely on capitation and risk settlements and on care management. And that's because the Medicare Advantage line of business has had a significant use of alternative payment models. Okay, Michael, I want to stop just for a moment. I see that there's some chats and some Q&A. Is there anything that I can clarify now, or shall I continue on?
No, why don't you continue? I've been answering the questions as they come in. So why don't you continue?
Okay, great. Thank you. Okay, so here is the annual growth in Medicaid total medical expense by service category. Not surprisingly, long-term care, which represents 33% of the total medical spending, is our highest here because of the population. This grew at 8%. Pharmacy growth was also high, although relatively low in terms of overall spending, which was at 23%. And then the third highest growth rate by service category is other professional. And other professional, in the definition that we used, it consists of behavioral health providers and some PT, OT, speech, and other providers that may not have necessarily fallen into a specialty or professional category basis. In terms of, there's a couple things I wanted to highlight, specifically diving in and looking across all of the different markets, and that is on hospital care. What we saw, as I mentioned earlier, is that spending on outpatient hospital services was the fastest growing category of spending. And we think that care has been shifted from inpatient to outpatient, which is consistent with national trends. However, the payer-reported aggregate data can only lend so much insight, and APCD analysis would be required to further identify to what extent it's site of service substitution from inpatient to outpatient, or from medical office to hospital outpatient, or new outpatient services and or volume. So there's some more detail that would be needed to further completely understand this trend. But it gives us a sense of where we can begin to explore the rich data source of the APCD. And finally, I wanted to note that Medicare was the primary driver of the statewide overall trend in hospital spending. And you can see that here through the darker or the sort of medium shaded blue bar here. And then finally, this table at the bottom here describes the percent of total spending by service category. And so you can see Medicare, a quarter of their spending, of all healthcare spending, is devoted to inpatient care, whereas a total of commercial spending, excuse me, a quarter of commercial spending is devoted to outpatient care. Now I want to talk a little bit about the net cost of private health insurance. This is a concept where we are trying to identify the total spending in the state, and that includes the administrative expense of administering private health insurance. And what we did here is we used publicly available data to calculate premiums less claims. And I want to note that there can be some significant volatility of the net cost of private health insurance trends due to profitability and loss issues. So I want to highlight here, as you see in the individual market on this table, there was a 169% increase in the net cost of private health insurance. Well, we know that in this particular market, there was one plan that had a loss in 2017 and then some profits in 2018. And so it creates a really large swing. So it's important to understand the context behind these numbers, but we think it's still an important part of the overall spending on healthcare in the state. And then I finally wanted to share with you some information on commercial market enrollment. And here you can see that the self-insured population shrank slightly while the individual market grew. This may be because of, at that time, the gig economy was pretty hot. And so individuals may not have been covered under employer-based health insurance, but maybe have gotten on their own. And obviously this trend will look different when we look at 19 and 20 data in the future. So at this point in time, I've presented all of the data that I'd like to review with you today. If there are, I believe we're going to be doing questions through the Q&A. Michael, are there any questions that came up that we should discuss?
Yeah, let me share a few. First, let me tell people that a YouTube video of this meeting will be posted on the OHIC website in a week or so, and we'll also have the slides available there. Megan, there are a few questions that have been raised that I've answered, but I think you can address. One is how were hospital community free services considered in calculating TME? That's one. The second is how are risk share or gain share arrangements handled in calculating TME? And then finally, whether the self-insured commercial lives are included in the analysis.
Sure. Okay, let me start with the community services that are provided by hospitals free of charge. That information is not included in the total medical expense data. The data are really the spending from a payer to a hospital, to any provider. And so if a provider is providing services that are not being paid for by a payer, those data are not collected. The second issue on risk share or gain share. So what we collected was the data by service categories I mentioned, and we had several what we called non-claims categories. That included dollars paid on the basis of capitation, for example, or through incentive programs. And what we would expect to see if there was an arrangement where there's risk sharing and the provider did not have gain sharing, then we would expect to see a negative number there. So this kind of payment to providers or vice versa, depending on the performance, is included in the total medical expense. And then finally, yes, self-insured data are included in here. We asked all payers to provide us with aggregated data on all of their Rhode Island residents, regardless of where they received care, and regardless of where the policy was administered.
Okay, I've got a few more.
Great.
Is out-of-state spending included in the analysis?
Yes, it is. So if a Rhode Islander spent the winter in Florida, which sounds like a delightful proposition, any spending that occurred in Florida was included, yes.
Okay. There's a related question. How does care delivered in Massachusetts and Connecticut compare to cost of Rhode Island care?
That is a great question. And conveniently, both Massachusetts and Connecticut is developing a cost growth target. And we anticipate that in the future, there may be able to do some state-by-state comparisons on healthcare spending using similarly developed public policy programs as well as data specifications. And so that's something that I think we can answer in the future, but not at this point.
Another question, where are emergency department visits categorized?
Where are emergency department visits categorized? I used to have the Bible in front of me of the data specification. I believe that it's in hospital outpatient. I can tell you that the definition exists on OHIC's website in the implementation manual, but off the top of my head, I can't recall that.
Okay, so there's one comment that was made that the Rhode Island's uninsured population as a percentage of the total population is quite small. So uncompensated care should be low relative to what we spend on the insured population. Next question, is growth in outpatient spending attributed to sicker patients being managed through home care services?
We don't know that from the data that we have as part of the total medical expense data collected from payers. That is a great example of a line of inquiry that the APCD data could help us understand. Should that be a line of inquiry that is of interest to the state?
Okay, and someone apparently looked up the specifications, Megan, when you were unsure, and confirmed that ED visits are in hospital outpatient spending.
Thank you for doing so.
So I'm going to actually introduce Betty Rambur. We're so fortunate to have Betty. She is a steering committee member. She is the Rother Endowed Chair for Practice at the College of Nursing at URI. And Betty's going to introduce the panel. We want to make it very clear that we understand the pressure that providers have been under. We understand that the transition to telehealth and remote healthcare has been a huge learning experience for all of us. And our next panel is comprised of providers and health system leaders who will share their experiences and their lessons learned from providing care through this pandemic. So I'd like to turn it over to Betty, and thank you so much for facilitating the panel.
Thank you so much, Commissioner. I'm really pleased to welcome our distinguished panel. Dr. Tim Babineau is President and CEO of Lifespan. Dr. Al Kurose is President and CEO of Coastal Medical. And Dr. Megan Ranney is a practicing emergency physician and researcher and a frequent and excellent contributor on CNN. So thank you all so much. I'm going to start with a question directed to all of you, but I'll start with Dr. Kurose. What are the greatest lessons your health system, group, or practice has learned from the COVID-19 pandemic?
We were pushed to innovate rapidly. Certainly the rapid implementation of video conference visits and telemedicine was a big piece. But there have been lots of other technology use cases that have really come to the forefront during this time. So we could point to the use of Google Voice and asynchronous text messaging to our patients as a real improvement in efficiency. We could certainly point to the total redesign of our workflows in the offices, how we use designers, architects to look at all of our floor plans to help us design flow for social distancing and for the safety of staff and patients. There's also been cultural changes. I think that we've been able at Coastal to serve the individual offices in a new and different way that has really brought us all closer. So there are many lessons, but specific use of technology, operations, cultural changes, communication, a host of lessons we've learned, I think.
Thank you. So I'll talk both from my perspective. I'll kind of talk from three different perspectives. First and foremost, I'm a practicing emergency physician working in Dr. Babineau's emergency departments. I work at both Miriam and Rhode Island. I also run our Brown Lifespan Center for Digital Health. And then, as you mentioned, I have run some national work around response to COVID and access to PPE. So from the ED perspective, this has in some ways dramatically shifted how we take care of patients, but in other ways hasn't changed a thing. At the end of the day, we remain open 24/7, 365 for whoever walks through our doors. We very quickly pivoted with the support, certainly at our Lifespan hospitals, of the larger Lifespan team to retrofit a number of our emergency department rooms to maintain adequate negative pressure and isolation, and to make sure that we adequately separate patients in our waiting rooms. And we've just continued business as usual, trying to take care of all of the health problems of Rhode Islanders, while also recognizing the huge variations in care and in the types of people that came to us during the early months of the COVID-19 pandemic, over the summer where we saw higher rates of trauma, and now where we're of course seeing COVID visits go back up again. And I know Dr. Babineau will talk more about the Lifespan response, so I will let him handle that part. From the perspective of the Center for Digital Health, as Dr. Kurose already alluded to, we've seen a tremendous increase in interest in the use of digital health tools, things like apps, text messaging, remote monitoring and wearables, telehealth certainly, but I think of telehealth as being kind of the tip of the iceberg in terms of both what's available in terms of digital health and also in terms of what is useful in terms of digital health. And through the Center for Digital Health over the last few months, we've piloted apps to help support patients who are in recovery from opioid use disorder to allow them to get asynchronous remote peer support. We've developed an app to help patients assess their risk of COVID-19 infection, given various everyday activities. And we're working on a number of other projects going forwards. We helped some with some of the early state response on the technology side, and then looking at other products going forwards, knowing that this virus is going to be around for a while. So I think one of the big things that COVID-19 has done for us is highlighted again, both the importance of that digital health, the importance of the investment in it, and also the ways in which you really can do it without driving either our patients or our providers bonkers. And I think one of the barriers had always been this perception that, oh gosh, we're already also overwhelmed with electronic health records. We can't add in more technology. Our patients won't know how to use it. And this pandemic has illustrated all too well that people are absolutely able to use it and interested in doing so. And then the last thing that I will say that this has changed is I think that it has made all of us much more aware of the fragility of our healthcare system in general, and particularly of our supply chains. Again, I will let Dr. Babineau talk about our hospital's experience, but I will say on a national level, the utter failure of our country to manage adequate supplies of personal protective equipment for healthcare workers across the country. Again, leaving aside hospitals, looking at nursing homes, at home healthcare providers, at clinics, continues to astound me, as do the continued shortages in basic pharmaceuticals and testing supplies. And I think, all three of us have dealt with those issues for a long time, but the Band-Aids have been ripped off during this pandemic. All of the stopgap measures that we've put in place in order to deal with the inefficiencies in our healthcare system have really been uncovered during the pandemic, and we've had to come up with new solutions, and sometimes there aren't solutions to come up with. And so I think it has given us a chance to reimagine what we would like to see, and then to advocate hopefully for some systemic changes that will help us not have to go through these major deficits in supply chains in the future.
Good afternoon, Betty. Betty, it's not fair to put me on after Megan. She's such a pro. It's like, the Ed Sullivan Show. You never want to follow the animal trick. Megan's such a pro, and it's great to have her on the team. I agree with what Al and Dr. Ranney has said. I'll pick up where Megan left off. And that is, she's absolutely right. It was stunning how fragile our supply chain in this country was. You would never think that for a country as rich as ours, that we would be hampered in our ability to deliver patient care because we couldn't get our hands on essentially a Q-tip to test or paper surgical mask. If you had said 6 months prior to COVID, we would have that, people would say, you're out of your mind. And yet I would say when we were in the middle of the real heat of the battle, I was spending a good part of every day of my day making phone calls, calling in favors, calling CEOs of companies who I went to school with 3 years ago and said, hey, can you send me 400 extra Cepheid test kits? So it exposed a really vulnerable part of our healthcare system. I think we learned a lot of lessons. I think we're better prepared today than we were back in the spring. It's still not perfect. It still has a long way to go, but I think it's something that we need to pay a lot of attention to. It just should not happen. And that puts aside all the black market stuff and all the fraudulent K95 masks that we spend enormous time chasing. So I agree with Megan's supply chain. Secondly, I'd just say quickly, it's all about our workforce, right? We have a resilient workforce, but they went to war. And it's all about protecting our workforce. We have to take care of our workforce, not only from a PPE standpoint, which I think we did a reasonably good job at, but acknowledging and addressing the severe mental health stress that resulted in these caregivers taking care of these patients. Some are still recovering just as we're about to head into the second surge. I think we need to pay a lot more attention to the physical and mental health well-being of our workforce. I know we do. I know we have. It's not enough. We don't have a workforce. We can't take care of patients. And then the last lesson, and there were many more, but I'd say the big lesson for me, for all of us, was really the dramatic unintended consequences of delaying care. People sitting at home having their heart attack, people sitting at home having their stroke. Our cancer centers said, they were seeing, when eventually we were able to bring the elective cases back, they were seeing advanced stage cancers present that they hadn't seen in this country in 20 years that you only hear about in third world countries. So I think we learned a lesson that there's a big, big price to pay for shutting down so-called elective procedures and elective cases. Just because you're on this OR schedule as an elective case, but if it's to remove your brain tumor, that's hardly elective. And heading into the second surge, and you may note today that the positivity rate in the state of Rhode Island is the same as it was at its peak in April. So that's a little bit concerning. We need to figure out how to co-manage the patients we usually take care of alongside the COVID patients. Remember, back in the spring, we primarily took care of COVID patients. We have to do both, and we're planning for that, but that will present a challenge. Thank you, Betty.
Great, thank you all. That was a perfect segue into the second round question. As you know, it's been reported that some people delay seeking care because of COVID fears, and clearly this includes some necessary care. But given the magnitude of the overtreatment and low value care that we've talked a lot about in this committee, it likely included some unnecessary or low value care as well. It's been suggested that this creates a natural experiment in which we can really tease out what care really matters to people's long-term health outcomes. Thoughts on this? And I'll start with you, Dr. Ranney, on this one.
From the perspective of an emergency department provider, I will say that our ED visits are still down year on year at this point. So certainly we saw a huge drop in ED visits, as Dr. Babineau mentioned, in kind of April, May, when we were in the statewide shutdown. And we saw a rise then in both the percentage of our patients who had to be admitted and in the number of really sick patients with things that could have been avoided. But even now in October, we have not seen our volume come back to where it normally is. And we're admitting a higher percentage of our patients. To me, as an emergency provider, I went into emergency medicine because we are the safety net for the healthcare system, but also again, because we provide that 24/7 diagnostic capacity, which I know we have a lot of insurers on this call. We get a lot of people who come in because you can get your testing done and you can get answers in a short period of time. We serve an essential function for people to triage and to figure out, is this worst headache of my life really a subarachnoid hemorrhage, or is it just new onset migraine? Is this chest pain really GERD, or is it actually an atypical presentation for a STEMI or an NSTEMI? And when we see our ED visits go down, we then see the people that come to us coming with later stage presentations of those same problems. So I would say that to me, and I look forward to having this discussion in 6 months or a year when we actually have the data, but anecdotally, it highlights that a lot of what comes to us is actually very necessary care. And I know that we've done a lot that, Al and Coastal, we've collaborated closely with you on trying to divert people away from us when possible. There have been a lot of really interesting, novel collaborations and attempts to try to help patients self-triage, but they don't work by and large, because the reason why people come to the ED is because we have that diagnostic and therapeutic capacity. And so from my perspective as an emergency physician, as well as from that public health perspective, the preliminary data that we're seeing, as well as the anecdotes that we're hearing, suggest that this is a failed experiment, and that there certainly may be a percentage of those visits that are unnecessary, but a lot of them, we just don't have another place in the system that can do that quick diagnosis, treatment, and triage as effectively as we can in the emergency department.
Great, thank you. Dr. Kurose, your thoughts on this?
I totally agree that we need to temptation to rush to judgment here, to think that we understand what the outcomes are. I think the dynamic here is very complex, and certainly every indication is that this is a real and serious problem that occurred with people delaying necessary care. And I think as we look at the patterns of cost and utilization during these past months of the pandemic, it's probably a mistake and an oversimplification to think that what we saw was just a demonstration of an elimination of low value care, because we saw the loss of a lot of high value care, and we see people presenting with advanced stages of disease. So totally accept all of that. At Coastal, one of the things we pivoted very quickly to telemedicine and video conference visits. We were also proactive in reaching out to subsets of patients that we thought were particularly at high risk in the setting because of chronic diseases and advanced stage and so forth. I think that probably for us mitigated the dynamic of people missing much needed care, because at least they were having a conversation with a provider where we would gain an awareness of that. So I think that maybe one of the lessons here is that when there are barriers to face-to-face care, the more access and contact we can offer to populations of patients, particularly those that are at highest risk, there may be a value in mitigating some of that dynamic that Megan was speaking to.
Great, thank you. And your perspective, Dr. Babineau?
Yeah, I agree with Dr. Ranney and Kurose. I think it's too early to draw any conclusion about whether we eliminated much quote unquote unnecessary care. However, the thing I think we have proved, is that when you limit access to care, costs go up and quality goes down. So we had that experiment in real time. So if you delayed your care of your heart attack, stroke, or cancer by even 3 or 4 months, your outcome was not as good had you come in earlier, and the cost to treat that patient goes up. So it supports the notion that if we're going to try to control cost of healthcare, increasing access to healthcare is really, really important. And if the price you pay theoretically is perhaps you deliver a little bit more quote unquote unnecessary care, net, I think it's going to turn out to be a cost savings. So that's the only other point I would make.
Great, thank you. I'll start this next question with you, Dr. Babineau, since you brought this up a bit earlier, and maybe you can expand on it a little bit. How have you supported the mental health of nurses, physicians, and other frontline workers and addressed the burnout given the intensity and long duration of the pandemic? And do you have lessons learned that you can share, or conversely, are there valiant efforts that failed that might also provide some fruitful learning?
Yeah, well, I'm sure all three of us could talk about this for quite a while. It's such an important topic. I'm sure, like Dr. Kurose and Dr. Ranney, we did a number of things. We stood up an employee access mental health line. So we increased the availability of and accessibility of our healthcare providers. Dr. Jody Underwood, our chief of psychiatry, just did a terrific job making her physicians and extenders available 24/7. And I will tell you, our employees took advantage of that. The number of requests for mental health assistance increased nearly 25% during the pandemic. Number two, you have to encourage people to take advantage of what you put in place, good, bad, or indifferent. There is still a little bit of a stigma attached to, I'm having challenges with my mental health. I need help. People are still reluctant to reach out. So we've really encouraged people to do that, and it's paid off. Third, giving folks time off. Just giving them a day or two off matters a lot. And then I would say that it wasn't a spectacular failure, but free pizza only goes so far. I mean, it's important to deliver food to the workers, but after a while, it doesn't do all that much. So it's really about the mental health, trying to give them some time off and encourage people to access what services you provide.
Great, thank you. Dr. Kurose, your perspective?
So I want to start by acknowledging what a tremendously valuable service intensivists, inpatient hospital providers, emergency physicians offered in this period of time. And I think their experience and their challenge is a little different than outpatient primary care, and I should definitely acknowledge that. And so I absolutely honor what Dr. Babineau was talking about there. For us, it was a little different because the challenge was also about just how does an outpatient primary care physician, how do they deliver care under these circumstances? There's a lot of practical issues. How do we get them PPE? How do we help them be able to use the video conferencing technology? How do we help them understand what the payment rules are and how they're supposed to do their billing? And how do we, for us, a couple things seemed to be valuable. One was to do a ton of regular communication and involve as many stakeholders as possible as having real input into our design and implementation of new workflows. So having very regular meetings with staff and office managers and providers where they could both receive information about what the payers were doing and what the information was of Department of Health, and also are taking their feedback on what their experience was on the front line and trying to change their experience. Because I think it's different if you're an intensivist dealing all day with critically ill patients in an ICU setting versus you're a community-based physician who in some respects is still like trying to run a small business while also delivering the best clinical care and making everything work for their staff and their patients, keeping everybody safe. So for us, I think, being inclusive, doing a lot of listening, being very careful, staying very connected, and using, fortunately for us, we have scale enough that we can dedicate individuals on centralized teams to assist in this process. Early on, even the process of following patients who had contact or patients who were diagnosed and figuring out how to keep track of them. Every one of these details, if they're not sort of handled well, just add to the stress of all the care teams. So different challenge for us, much gratitude to the hospital and emergency providers that did the hardest work.
Thank you. And I'll go to you next, Dr. Ranney. And I would just also like to mention, we have Lifespan here in Coastal. We did have another panelist from another part of the system who was not able to be here. So just to be clear on that. Yes, same question, please.
Absolutely. So I'm going to talk about a couple of different things. I won't repeat what Dr. Babineau and Dr. Kurose already said, but I'll say first to just reiterate how real the stress was and how much more fearful I am actually about this fall and winter than I was about the spring. In the spring, this was a brand new thing. We all came together. In many ways, it felt like our response to a disaster. And many of us remember the station fire or the any of the other kind of mass casualty events that we've had where we join together as Rhode Islanders, do the right thing for our patients and make it through. And it's traumatic, but it's a one-time thing. The trouble here is that this has been going on now for 9 months, and it's now getting worse again as we're heading into the fall. It's getting dark early, and there's no end in sight. And our healthcare providers are just exhausted. As Dr. Kurose mentioned, they are facing financial stress. I have friends that run private practices who are have had to let employees go, who are facing, again, not kind of talking about the lifespan, but the larger system, there's just tremendous financial stress for providers throughout the state. And then add to it that they're having to purchase PPE, they have new expenses, and that they're facing these really sick patients and patients that potentially don't understand science, right? And are challenging them about the desire to wear a mask, challenging the decisions about whether they need tests, challenging them about the importance of quarantine and isolation, et cetera. Add on to that the fact that we're suffering from the same stressors that everyone else in society is around lack of coping mechanisms, issues with childcare. Again, early in the pandemic, the state stepped up, and I'll say Lifespan did an absolutely amazing job in making sure that healthcare workers had childcare. Right now, many of our kids are back in school. But when we're looking forwards to the fall and winter, none of us expect that schools are going to stay open throughout this winter season as respiratory virus season comes upon us. And so we're going to face, having your kids back home again and all of their stress on top of us still having to go to work and potentially taking care of a higher volume of really sick patients than we did in the spring. Within my own emergency department, we've done a lot about our Department of Emergency Medicine has done a lot around both formal and informal peer support, and then working with Lifespan, which their services have been amazing in terms of destigmatizing and taking away many of the barriers to accessing care. But we know that we as providers are really bad at admitting that we are facing any challenges, right? That's the whole part of medical training, is to be stoic and push through. And just as we're trying to remind providers, you've got to wear a mask when you're in the break room, we're also reminding them, although of course our break rooms are closed, but right, that you have to wear a mask when you're face to face. It's also reminding them that they need to take care of their mental health. Most healthcare providers have been taught to ignore their mental health as part of their training. So it's this enormous just shift in the way that we think about taking care of ourselves and taking care of others. I think that important things going forward are both the types of programs that Dr. Kurose and Dr. Babineau have talked about, making sure that we have those informal peer support, and making sure that the structural issues that stress out our providers are taken care of. It is about the access to PPE. It is about the financial stress. It is about the child care. It is about the ability to successfully quarantine and isolate if you're someone who's caregiving for an elderly parent, while we're going out and exposing ourselves to COVID-19 patients. And so I would encourage us to think about those larger systemic issues as well as the individual care issues.
Thank you. I certainly see the weariness in my graduate students who are mostly nurses, disproportionately female in their parenting years, and just feeling stretched and really careworn in so many ways. Well, we hope there's going to be positive echoes from this. But I'm going to start this question. It's really two-part, and I'll break it into two parts. I'll start this one with you, Dr. Kurose, and then move through to the rest of you. Years from now, when we look back, how do you think COVID-19 will have impacted the trajectory of health reform? Will the pandemic have slowed or accelerated progress on alternative payment models?
It is early to project how we'll be looking back. I do want to reflect on something Dr. Ranney said, because I think that one of the things that's going to change here, and maybe somewhat permanently, is our interactions with our workforce and the way in which they do their jobs. We've been focused on the frontline providers, but in any healthcare organization, there are lots of teams that work behind the scenes. At Coastal, many of those folks are working at home. That does help to alleviate the stress somewhat of school at home and childcare issues. And we're also having people on more flexible schedules where the data team can start running the reports at 9 o'clock at night if that's what they wish to do, and they can be with their family through mealtime and bedtime if they've got young kids. And I think that historically in medicine, we probably haven't been as flexible and creative as we might be. Ritualized training and process that we've adopted, and maybe we haven't been as progressive. So I think that one of the things that'll come out of this is that our HR policies and our interactions with our workforce will probably be more flexible and creative. And then in that manner, I expect actually that we'll get the best work out of our workforce in that way. And I think we're adapting quickly to be able to be productive. At this time where we've been in the pandemic for quite a period of time, we're probably close to 50% face-to-face, 50% remote care. Because when you look at a typical primary care office and you might have 7 or 8 docs there and you might have many teams working at once in a relatively small space, you cannot do adequate social distancing and match the face-to-face volumes. So again, this invention is the mother of necessity is the mother of invention. We are forced to do something different. We cannot do the same volume of outpatient primary care visits safely. So in addition to PPE and airflow and all those other things, just the constraints of space and a careful analysis of that are pushing us more towards remote care. A point that hasn't been made yet in all of this is that I think we have to recognize that our patients are a heterogeneous group, and their appetite for different ways of receiving care is highly variable. And I think we're still learning about that. So some subgroups of patients, some use cases, a video conference visit is sort of a slam dunk success. For others, either the patient or the physician may not be as comfortable with that. So while we're learning, and it's interesting to speculate about the future, again, my sort of mantra is let's not too quickly rush to judgment, because there's a lot of nuance here, and we need to take the time to understand what people's experience is and what they're telling us about it.
Great, thank you. Dr. Ranney, your perspective on this?
I mean, I'll just echo what Dr. Kurose says, and I just responded to a couple of Q&As that with exactly this, which is that what I think that all of us are presenting is right now either anecdote or small n, or it's so early to know. And I'll also say, of course, that what changes with our payment mechanisms depends a lot on what happens over the next month or so, both in the Supreme Court and in our federal leadership. So there are so many unknowns for me to speculate as to whether this is going to drive changes to alternative payment models. I just don't feel that I could reliably make those sorts of statements at this point. I have hopes. I mean, I would, right, there are certainly hopes there, but can I say it with any sort of certainty? No.
Thank you. Dr. Babineau, your perspective.
Yeah, thank you. I agree with what Dr. Kurose and Ranney said. I'll turn your question around a little bit, Betty, and that is there any silver lining to the COVID crisis? Because I can't comment on alternative payment models. I'll say there are a couple. Al touched on one of them. Despite the fact that our frontline healthcare workers are incredibly stressed out, as we talked about, we've got close to 1,500 people working from home. They like working at home, and they're more productive working at home. So at least for one aspect of our workforce, the shift to work from home has been a really positive benefit. And we won't even comment about the cost of our ability to shrink our real estate footprint and thereby lower our overall cost structure. So that's been a good thing. The second thing is, I think we learned we can move quickly when we need to. Healthcare is just this lumbering industry, the analogy turning an aircraft carrier, but we can move quickly when we want. We talked about telehealth for 2 years and made, 5 yards of progress. In 3 weeks, we got the ball in the end zone. So I think it taught us a lesson that we don't need to be as slow to change as we historically have been. And when we talk about alternative payment models, et cetera, I think we taught ourselves a lesson. We can move pretty quickly. And then last, and I think one of the most important lessons, I've been a big proponent of competition drives up cost of healthcare, collaboration lowers the cost of healthcare. And I think not only here in the state, witness, Care New England and Lifespan are back at the table trying to get together again. That's happening nationally. So competitive healthcare systems that spend a tremendous amount of money competing with each other, and I would argue wasted money, we saw less of that during the pandemic, and the CEOs that I talked to around the country have all said, you know what? Wasn't so bad to work with my competitor. In fact, our patients got better care when we did. So I think there's a little bit of a mind shift, at least in the leadership of big expensive healthcare systems that, trying to steal business from one another, trying to out advertise one another, trying to, the arms race of technology. Maybe that's not the right way to think about it anymore. So I'm cautiously optimistic. There's a bit of a new day dawning among healthcare systems that maybe we ought to find ways to work together instead of just competing the hell out of each other.
We've talked a bit about access and affordability and many things, but this conversation wouldn't be complete if we didn't discuss a bit about the disproportionate impact of COVID on communities of color. And are there opportunities for this really COVID crisis to help us change and do things differently down the line? Are the disparities going to be even worse? What are the lessons here that we can take forward? And I'll start with you, Dr. Ranney.
So as an emergency care provider, part of my underlying mission is to take care of everyone, no matter who they are, where they come from, what language they speak. I know that's all of ours, but in the emergency department, we don't even ask your insurance status before we take care of you. And we've always had a commitment in the emergency department to making sure that we pay attention to the needs of vulnerable and underserved communities. The disproportionate impact of COVID-19 on Black and Hispanic communities, to me, just throws into stark relief, once again, so many of the existing structural issues, both in our society and in our healthcare system. Going back to what I said before about how this pandemic has pulled off the Band-Aids of many of the things that we covered over within the healthcare system. This is just another example of how that is. These are not new disparities. These are things that have been there. And the reasons why Black and Hispanic people are getting infected and dying at higher rates is because of the types of jobs that are available to them. It's because of their access to PPE. It's because of their access to testing. It's because of our lack of translation of health education materials into Spanish, into Portuguese, et cetera. It's because of fear of the system. I could go on. So to me, this offers us potentially an opportunity to switch the way that we approach these populations, to make sure that we do things with a lens and an eye to equity. And again, not as much, certainly on an individual healthcare system basis, but I think of it more on a statewide basis. And I will say I have been tremendously proud to be part of a state that has done this so intentionally, with Dr. Alexander Scott's setting up the walk-through testing sites in addition to the drive-through in the collaboration with CVS to help develop and spread testing sites literally across the state long before any other states did. And I know that CVS is now nationwide, but that they the testing is now nationwide, but that they started doing that with us. I think that those were incredibly forward-thinking ways to address these disparities. Dr. Alexander Scott's use of people going literally from house to house in Central Falls, those are all essential, and those are things that I hope that we take with us. I will come back again to that digital health and technology point. I'll come back again to the digital health and technology point. One of our North Stars within our Center for Digital Health is making sure that our development of new technology is done with an eye towards equity. And so we are very purposefully trying to work with a wide diversity of populations and leaders. And so I think, again, kind of taking this forward to the next level, it's saying, how do we take all these changes that we've been forced into during COVID-19 and really institutionalize them? And also, again, how do we look at the systemic things that have gotten us to this point? And that may not be on the individual healthcare system. It's stuff that you guys do at OHIC. It's stuff that's done and at EOHHS. It's stuff that's done at the Department of Health. How do we use that to drive change in the underlying issues that resulted in this disproportionate impact on our Black and Hispanic communities?
Thank you so much. Dr. Babineau, your perspective.
Dr. Ranney said it all and said it incredibly well, as she always does. It just turned up the spotlight on an issue that we've known has existed for far too long. It turned up the spotlight on the importance of the social determinants of health. We need to do better. And as Megan said at the end of her comments, and I think it's a really important point, none of us can do this alone. It is a multi-system, multi-stakeholder effort. Lifespan can't do it alone. Coastal can't do it alone. Department of Health can't do it alone. And I think, again, the reason why I'm hopeful is at least for the last 4 or 5 months, stakeholders that sometimes worked pretty well together, worked really well together. I mean, our working relationship with the Department of Health was spectacular. And when that happens, good things happen. So I think we're going to build on the fact that when we really lock arms and tackle a difficult problem, we make some meaningful progress. You know, I know Neil Steinberg, I don't know if he's on the call, the Rhode Island Foundation's putting a ton of effort into this. I was delighted to see the $8.5 million grant. But I think we did a pilot project almost of let's really work together, not just say we're going to work together. And we showed that when that happens, good things happen. So I'm optimistic we will make progress finally in this area.
A couple of interesting comments that I want to share, Betty.
Thank you.
One is regarding the observation about the increased cost of delayed care. We will need to reconcile the increased cost of delayed care for individual patients with what appears to be lower healthcare costs overall, or lower trend. We are apparently seeing in insurer expenses. We'll have to be careful here. We will not know system expenses for a while. This is why the Rhode Island measurement efforts are so important to understand, if delayed, where the changes are happening. And then there was a follow-up comment about how at Blue Cross, they've studied the effect of delayed care and found the largest drops in diagnoses have been in obesity, substance use, cerebrovascular disease, hypertension, and malignancy. The first two likely due to fewer face-to-face visits, the latter three likely due to later presentation.
I just wanted to add the comment that to the extent that we are talking about disparities and inequities, and we're talking about social determinants of health, there are going to be a lot of engagements where the healthcare delivery system is going to be a participant, but not the lead participant. I think we have to understand that. You know, the numbers tell us that healthcare has a 10% or 15% influence on health outcomes. For us to get to a place as a state where we can collaboratively with community-based organizations and community leaders.
I did have a closing question that actually dovetails nicely with that. Could we just close by you suggesting 1 or 2 changes that your organization has made or tried to make that you believe should be carried forward as a best practice, a promising practice or best practice post-pandemic?
I'll go back to what I said earlier, which is just a really intensified focus on our workforce, on their physical well-being and their mental well-being. We can't let the efforts that we put in place in COVID go away when COVID goes away. It's just too important. We all know there's an issue with, you know, burnout and resiliency of our physicians, our nurses, our housekeepers, everybody. So the things that worked during COVID, we need to just do 2 and 3x going forward. And then second, just encourage people that if they have an issue, come to the hospital. We're open, we're safe, we're ready. The hospital is not a dangerous place to come. And encourage people to get access to the healthcare they need. I would say those are probably the 2 biggest lessons for us.
Great, thank you. Megan, do you want to go then and
Sure.
help getting yourself set up?
Yes, absolutely. Thank you. Those are great, Dr. Babineau, and I fully agree. I will add on to that 2 more things. One is to continue to hold this fire for innovation in digital health and technology, and recognize that we can push the barriers a little more quickly, and that we can use technology effectively with a wide variety of populations, and to commit to doing that and to iterating quickly. The second is the commitment to public health communication with a diverse segment of our society. And I think that if we take nothing else away from this, it is going to be that we're going to have to really rebuild the public's trust in medicine and public health over the next year or 2, and that we're going to have to continue communication, but that just because we're doing it during COVID-19 doesn't mean we shouldn't take all these lessons and apply them to all the other health problems that we normally would be talking about. All those other epidemics haven't gone away. We still have obesity. We still have opioid overdoses. We still, you know, I could go on. So I hope that we'll take the excellent strategic communications that we've had in this state, expand them nationwide, and double down on that communication.
You know, there were a number of state and federal regulations that were loosened during the COVID that allowed us to be a little bit more agile, a little bit more nimble, a little bit more quick to react to a situation. So I think we learned that while regulations are necessary, both at the state and the federal level, perhaps there are some that do more harm than good. So I'm hoping that all of us, legislators, government leaders, healthcare leaders, take a fresh look at all of the regulations that are in place and see if all of them are necessary. Because we were able to do things once the state and the feds in their wisdom said, you know what, for the time being, you don't have to worry about that. There was a real benefit to that.
And then the closing question was, are there something you have done in your organization or tried to do that should be carried forward and become a post-pandemic best practice? So you get the final word.
You know, let me try one more time to see if I can say anything about the inequities and disparities, because that I was trying to talk to before. I think that, you know, the long-term health plan convening by the Rhode Island Foundation is a great start. I think that Dr. Ranney is correct that we have a level of activation and focus collectively right now that we should really maintain that momentum and go forward. One of the things that we can do is make sure that we have the right public health metrics, that we keep them in front of everybody, and that we hold ourselves accountable to improving those markers. You know, you never want to waste a good crisis, and this is one that could really be a catalyst for movement in that direction, but it's far from guaranteed. And we also know, unfortunately, that economic hard times are coming. There's budget pressures. We shouldn't kid ourselves about that. That's going to be a real challenge, but we have to take the long view. And I think, you know, a 10-year plan with the right metrics, with the kind of focus that's been created in this moment of crisis, gives us a real opportunity and a real shot at improving some of the very long-standing, systemically driven disparities that we see today.
Thank you so much. Thank you, all three panelists. And I know that if this was face-to-face, there would be a round of applause. Thank you so much for your time and expertise and all the hard work that you do during this time of COVID and always. And with that, I will hand it back to the commissioner.
We are now moving on to our issue of pharmacy costs. As you saw from Megan's presentation, that some of the data shows us that that may be an issue for us to focus in on first and foremost. So I would like to turn the platform over to our esteemed colleagues from Brown University. Dr. Ira Wilson will be presenting Brown's analysis of the APCD on pharmacy cost drivers and the other cost drivers. Dr. Wilson is professor and chair of the Department of Health Services, Policy and Practice at the Brown University School of Public Health. He is also the professor of medicine at the Albert Medical School at Brown. The team at Brown, including the project management by Anya Ryder-Wallach, have been key partners with us on this project, and we're very grateful for them. And I turn it over to Ira. Thank you so much.
So I'm not going to review anything that Megan Burns has reviewed previously. She did a nice job explaining that the data she presented is not identical to the data that we're going to use for these analyses, but the findings are strikingly similar. Couple points I would make just to reiterate. These are drug claims that we're looking at, and because of that, they are not net of rebates. And I'll come back to that briefly at the end. The second point I wanted to make is that as Megan did note, the data that we have includes both commercial payers, Medicaid, and Medicare. I'm not going to include any analysis of the Medicare data today because the drug claims, turns out Part D claims, are more than 2 years delayed. So the analyses I'll show you include 2016, 2017, 2018, but we have no 2018 data for fee-for-service or Medicare Advantage or duals. So the data I'm going to show you today includes only commercial payers and Medicaid managed care. But let me just say that's about half the people in the state, and I think the findings are very robust. Okay, the agenda, first we'll talk just a couple definitions because we want to separate and look separately at retail pharmacy costs and medical pharmacy costs. We'll next talk about pharmaceutical costs as drivers of total cost. Then pharmaceutical costs as drivers of cost trends, that is to say the increases we see over this 3-year time period. Following that, we'll talk about the issue of are the price increases, the cost increases, which you've already seen in Megan's presentation. So it's no surprise. You saw lots of evidence that one of the most important and fastest rising part of healthcare costs is indeed pharmacy costs. I'll break this down into utilization and price. Many of you already know that the main issue here is not utilization, but actually price. We'll demonstrate that in detail. Then we'll dive down a little bit deeper into both the retail pharmacy costs and the medical pharmacy costs and conclude. Okay, so this is just a little bit of a quick definition, which many of you probably know. Retail pharmacy costs, or the retail pharmacy spend, refers to prescription medicines that are purchased in retail pharmacies. And most claims data sets have a separate category for retail pharmacy. However, there are drug costs which occur in other parts of the medical spend. And what is called medical pharmacy costs or medical pharmacy spend refers to prescriptions that are administered, usually by infusion, actually, in providers' offices or in hospitals. And we break that out because it's less appreciated by many as an important part of the overall drug spend. In fact, it appears in claims files as part of professional services normally. They're identified by something called J codes for those of you who might be interested in that. But most importantly, and as I'll show you, they are growing rapidly, so they deserve our attention. So first we'll start off with some data on drivers of total cost. So this stacked bar graph looks at the total per member per month cost of commercial insurance. The numbers that you saw earlier were per member per year. These are per member per month. If you multiply these numbers that you see at the top of the stacked bar graph by 12, you get numbers that look very, very similar to the ones that Megan Burns showed you earlier. And you can see there's 3 columns. The first is 2006, then 2007. I'm sorry, then 2017, and then 2018. And the ends are the number of members that contributed to these data. So you can see there are a lot of commercially insured patients in the state. The bars themselves, the green is inpatient, the lighter green is outpatient costs, the red is professional services. We're going to spend most of this presentation on the teal, which is retail pharmacy, and the navy blue, which is medical pharmacy. And there's a little needed to balance, which we characterize as other. So next, what I'm going to do is to break down the teal and the blue and compare it to the rest. So you can see the way in which pharmacy costs drive total costs. So each pie chart is a year, 2016, 2017, 2018. This is commercial insurance again. The gray is all the other components of cost that we're not going to pay much attention to today. The teal is the percentage that is related to retail pharmacy, and the navy blue is the percentage that's related to medical pharmacy. And the message I think you can see here is pretty simple. The teal grows from 22.8 to 23.2 to 23.6. And the navy blue grows from 2.9 to 3.2 to 3.8. So retail pharmacy and medical pharmacy are a significant fraction of total costs here, 25% or greater, and it's growing as a fraction. Next, I want to just take you through the same 2 slides, but for Medicaid managed care, and I'll go a little quicker because you've already seen this. Again, you've got 3 years. You can see the total costs per member per month are at the top of the stacked bar graphs, and the colors are the same. So next, I'm going to show you the pie charts. So the numbers are ever so slightly different, but you can see the pattern is the same. If you look at teal for Medicaid managed care, the teal is a little bit flatter, 19.9, goes down a little to 19.0, and then up to 20.4. But look at the medical pharmacy. It goes from 3.2% to 3.6%, and then up to 4.2%. So again, for Medicaid managed care, pharmacy costs are a significant part of total costs, and they are growing. Okay, so the next thing I want to talk a little bit about is what is driving the total cost trend. And I'm just going to show you data you've already seen, but in a slightly different way. So this graph shows the drivers of the cost trend for commercial insurance. And what this shows is the cumulative change in per member per month from 2016 to 2017 and 2018. In these cumulative changes are just subtracting the numbers at the top of those stacked bar charts that you saw earlier. And if you look at the teal and what in this graph is a little bit purple, you can see that over 2 years, 18% of the increase was due to medical pharmacy and 36% was due to retail pharmacy. So a total of 53%. So more than half of the trend can be explained by pharmaceutical costs for commercial insurance. The numbers are a little bit different for Medicaid, but again, this is the same diagram and it should be understood the same way. You can see that 16% of the 2-year trend is related to medical pharmacy and 25% related to retail pharmacy for a total of 41%. So under half, but just over 40% of the trend can be explained by pharmaceutical costs. Okay, now we're going to dig a little bit into, we've just been talking about total costs, but how do you understand that? What's really going on? And as most of you know, for almost anything in healthcare, you need to understand what is the effect of utilization. For example, are more physicians prescribing more drugs for more people, or is the utilization stable, and is most of this increase explained by price? So first, we're going to look at commercial insurance. And what I would ask you to do is just look at the blue part of this graph, which is labeled as pharmacy. That's retail pharmacy. And the first thing I'd like you to do is look at the blue line with dots. And you can see that there is a 9.8% increase over 2 years. So that's the increase in retail pharmacy spend. Now, the other two lines represent a decomposition of that total cost increase into a utilization piece and a price piece. The utilization piece is in the dotted line, and you can see that the 2-year trend actually goes down, minus 3.5%. So what that means is there is actually less use of pharmacy. Well, then how do you explain that 9.8% increase? Well, obviously that's price. And if you look at the black line, you can see the price trend. So there has been a 13.8% 2-year rise in prices in retail pharmacy. Now to the right, you can see medical pharmacy, and you analyze this just exactly the same way. And you can see the green line with dots. There's been a 35% 2-year increase in the total spend in that area. And if you look at the dotted line, you can see it's not explained by utilization. In fact, utilization is a little bit down. It is explained, in fact, by price, and there's been a 38.7% increase in price. So cost increases are driven by price, particularly in medical pharmacy, where if you look at that last 2 years, the utilization actually trended downward and the price trended up impressively. So I'm going to now look at the same graph for Medicaid. And you can see that it's a little bit, the numbers are a little bit different, but the story is the same. And just to make this go a little bit quicker, for the pharmacy, I would ask you to just look at the the black line, and you can see that's price, and there have been a 10% 2-year increase in price. The dotted line below that, 1.2% is the increase in utilization, very small. And to the right, medical pharmacy, you can see that the total price increase has been 43.6%, very dramatic. And when you decompose that, 7.7% of it is utilization. So in medical pharmacy and Medicaid, there was a 7 or 8% 2-year trend. But in addition, or on top of that, there was a 33.3% increase in price.
Ira, we've got a couple of questions I'd like to share with you.
Go ahead.
So the first is whether within medical pharmacy, we're including home infusion.
Good question. I think, so most of the time, the drugs that we're talking about, and we're going to show in a little bit later, you'll see the kinds of drugs that we're actually talking about that are in this medical pharmacy group. Most of them are expensive agents, which are complex parts of therapy, which are given in doctors' offices. So I would say in general, the answer to that is no.
Okay, and second, there's a request for some reconciliation by someone who's noted that Medicaid MCO total cost numbers don't appear to align with what EOHHS has reported. EOHHS shows PM Medicaid costs going down. I presume that's for pharmacy here, or being level. They do report by fiscal year, not by calendar year, but there's a request to reconcile this eventually.
So we should reconcile these measures. We have done everything we can to map both the commercial data onto all the data that we can find publicly available about pharmacy, and similarly for the Medicaid data. And we would love to sit down with EOHHS and work out exactly what it is that is similar, what is that's different. Let me just also remind whoever is making a comment that this is not net of rebates. So that could be the source of the difference, although I don't know. Shall I go on?
Yes, thanks.
Okay. Okay, so now what I want to do is a little bit of a deeper dive into retail pharmacy costs, so you can see a little bit more about what is going on and understand some of the aspects of this category that make that can be described where these increases are occurring. So these stacked bar graphs they basically are just taking only the part of those first stacked bar graphs you saw that refers to retail pharmacy. So this is the total cost in PMPM of all the retail pharmacy drugs. And the company that we used to sort of classify and subclassify this pharmacy cost is something called Lexicomp, and they have actually 18 categories of drugs. And so what I've done here in the colors is just highlight the top 5 categories in total spending. So the gray is the 13 other categories of spending. One of the things that this graph shows, because we have the 3 years of commercial on the left and the 3 years of Medicaid on the right, is that indeed spending on drugs in the commercial sector is different and higher than in Medicaid, and this shows that very nicely. But you can also see that both are increasing. So the next slide just pulls out those 5 top categories so that the y-axis is spread out a little bit. And you can see the green is metabolic agents like insulin. The lighter green is respiratory agents. The red is immunologic agents. The teal is anti-neoplastic. Those are drugs for cancer. And the dark or navy blue is coagulation modifiers. And so the next thing I'm going to do is take each one of those 5 groups and decompose it into utilization and cost, just as we did earlier. So the graphs look just the same, although this is a little more complicated because I'm showing 5 sets of graphs on one slide, but the graphs are just the same. So from left to right, metabolic agents, respiratory agents, immunologic agents, anti-neoplastics, cancer drugs, and coagulation modifiers. So what you can see, if you just look across all of these categories at the dotted lines, you can see that utilization is flat to decreasing in commercial insurance across all of these categories. And if you look at the black line, you can see that price goes up in every category, in some quite impressively. Metabolic agents, it goes up 6.2%, respiratory agents 18.4%, immunologic agents almost 130%, anti-neoplastic cancer drugs 54%, and coagulation modifiers 23%. So again, the same theme, but because these are the top 5 categories, this is just a demonstration of how, when you look, drill down a little bit, you get the same picture. This is for Medicaid managed care. This is exactly the same thing. And again, each one's a little bit different. So if you look at the dotted lines, you can see, again, most of them are flat to decreasing. Although for coagulation modifiers, there's a small, an 8% increase in utilization over 2 years. And then if you look at the black lines, you can see, reading from left to right, there's 13% increase for metabolic agents, 6.8% for respiratory, 88% for immunologic agents, 72% for anti-neoplastics, and 91% for coagulation modifiers. So again, these are tremendously dramatic increases in price over a 2-year time period. And I thought I would just for illustration, you might be asking, what are these medicines that are increasing like this? So what I did is I just picked one of these categories, which was the coagulation modifiers, and I'm showing you data only for 2018. And on the top, as you can see here, is commercial, and the second lower part of the slide is Medicaid. And you can see that what I've shown is the indication for the drug, the paid amount. This is the total cost for 2018 for this particular drug for commercial insurers. This is the number of users. This is the number of prescriptions. And this is, when you divide those two, the price per prescription. And I just do this so you can see that for some drugs, they are moderately expensive per dose. That's the $355 on the right, but used by a relatively large number of patients, which means that the total paid amount is relatively large. But there are other drugs that are used. These are drugs, actually, this particular drug is a drug for hemophilia, a very rare sex-linked condition. And these are extremely expensive and used by very few patients. And again, I just wanted to give you some sense of the kinds of drugs that are in one of these categories. So the next thing I wanted to do was look a little more closely at medical pharmacy. And I want to remind you that what you just saw, the retail pharmacy, includes all kinds of drugs that are very, very common and have very, very low prices because they're generic. You know, some 80% are probably generics in this category. Almost none of the drugs in medical pharmacy are generic, and just keep that in mind. So this is commercial insurance, and each pie chart is a year, 16, 17, and 18. And what I've done is, in the teal, this is the percentage of the total cost in this category that is accounted for by the top 5 drugs. And in the rust colored piece of the pie, those are in the drugs that account for that are the numbers 6 through 10. So if you add together those two, what that suggests and indeed shows is that more than 50% of the spending in this category is accounted for by just 10 medicines. Now, what I want to show just below this is the percentage of patients covered that actually use these drugs. And if you, the way to read this is that this teal category, 3%, I'm just looking at 2016, 3% of the patients here account for 36% of the cost here. So if you add these two together, about 4.7% of the patients account for more than 50% of the costs. And that is a pattern that you see across all of these years. So this is for commercial insurance. The numbers are a little bit different for Medicaid, but not that different. You can see that just less than half of the spending is on just those top 10 drugs. And again, it's a relatively small number of people that use those top 10 medications. And I just wanted to show this slide because it is set up the same as the slide I showed you earlier. I just wanted to give you some idea of what sorts of drugs and what kind of diseases fall in this category. So the description is the drug name, the indication are the kind of conditions that they're used for. The paid amount is the total amount per year in the top part in commercial insurance and the lower part in Medicaid that is spent on these drugs. The next column is the number of users, and you can see it's a relatively small number of users and the number of claims. And then when you divide those, you get the cost per use. The way to think about this for these drugs is the cost per infusion. And you can see these are extremely high costs. Just to take you back a minute over to the description where you have the names of the drugs, most of these end in MAB, right? Those are actually monoclonal antibody drugs. So these are proteins that you can't take orally because they would get digested in your stomach by stomach enzymes. That's why they have to be infused. And that's why often or virtually all of these are infused in doctors' offices. As some of you know, there are some injections which patients are able to give themselves in their home. Most of those will be in the retail pharmacy group. So just to summarize the points I wanted to make about medical pharmacy, there are dramatic price increases over this 2-year time period, and a large portion of the medical pharmacy spend is on a relatively small number of very expensive drugs that are used by a relatively few beneficiaries who have uncommon conditions. So just to conclude here, a couple of data considerations, some of which you've heard before. The commercial data doesn't include claims from self-insured employers who elected not to submit. I know someone asked earlier whether or not it excludes all of the self-insured. It does not. It includes only the ones that elected not to submit. It also does not include claims from Blue Cross of Massachusetts, which we recently discovered are wrong. And that's about 20,000 covered lives per year. The total cost data excludes non-claims-based payments. You heard Megan Burns talk about that earlier. The data excludes manufacturers' rebates, which vary in magnitude in the range of 10 to 20% of the total pharmacy costs. And if we were able to adjust for those rebates, which we can't, it would reduce the costs that we show. So in conclusion, you all know this already, pharmaceutical costs are an important contributor to both costs and also to trends or increases in costs. Medical pharmacy is an important component of the total pharmacy costs and should be monitored closely. I hope that there are a number of people here who haven't previously thought about quote unquote medical pharmacy costs as part of drug costs. And I hope this convinces you that, that indeed they are. Price, not utilization, is what drives these cost increases. And so the logical conclusion is therefore that interventions to control pharmaceutical prices are very much needed. This is certainly true in the state. It's true nationally as well, as most of you know. So thank you. And I will take questions if there are any.
There are. So we've got a couple of questions first that are on the same theme, and that is whether the price increases that have been observed are the effect of new drugs or old drugs. Can you comment on that?
I think it's both. We have not, we actually had that same question ourselves, and we've not finished our analyses of that issue.
Okay, thanks. Someone else said, concern, need to look at specialty pharmacy.
Well, there may be someone here who knows more about that than I do, but my understanding of specialty pharmacy is that there are some drugs which appear under the retail pharmacy category, which come from specialty pharmacies, and the large majority of the drugs which appear under the medical pharmacy category come from specialty pharmacies. But it's not a one-to-one mapping.
Okay. There are a couple of questions about biosimilars. How do you account for biosimilars use that have recently hit the market? We need to be looking at biosimilar use like you look at generics.
So we didn't pull out and separately look at biosimilars. The only, so I can't comment on what the data show us, but I think it is fair to say that biosimilars have not taken off as a component of particularly like medical pharmacy costs the way it was anticipated that they would in light of the changes in regulations related to biosimilars that the ACA introduced. But that is a good question, and it's a good thing to look at more closely in the future.
A similar question someone asked, were you able to look at what the savings might be if biosimilars were used instead of Remicade, for example?
So that is absolutely doable, but we haven't done that yet. So that's a good idea.
There was a question about whether any comparative analysis has been done between the cost of the drugs in the United States and Canada, including those listed on slide 23.
So we didn't do that, but and I can see Trish Riley nodding her head. I can tell you what the results of that comparison would be without even doing it. And that is that any of these drugs purchased in Western Europe or in Canada are dramatically less expensive, sometimes in the range of 25 or 30% the cost, although it really varies tremendously, but they are all a lot lower. And that indeed is the focus of what we want to talk about next.
Great. One more question. Did you look at the disparity between hospital-based infusion centers and freestanding centers?
Also an interesting question. My suspicion is that for a given type of insurance, that the cost of the drug isn't going to vary, because that's a J code, isn't going to vary according to site, but the facility cost, which would show up in the outpatient category, might differ, and that is an interesting thing to potentially look at. For example, one might hypothesize that the facility cost at a hospital-based infusion center where a specialist practiced would be higher than a non-hospital affiliated infusion center. And so that's a reasonable hypothesis. I don't know if it's true in our data, but it is something we could look at. It's a good thought.
Okay, and one question that I missed before. For medical pharmacy, how do you define a unique medicine? Question mark J code.
Each type of medicine has a separate J code, and so but I don't know beyond that what's implied by that question. I'd be happy to take some clarification if that would be, if the follow-up is helpful.
Okay, so if the person that asked that question wants to clarify what she meant, please do so. Otherwise, that is all the questions that we received.
Now I think everyone can understand why we've decided that looking at the pharmacy cost piece might offer an opportunity for us in Rhode Island to actually make some policy changes. And we had invited our next speaker actually to meet with the Cost Trend Steering Committee when we were meeting face-to-face. She gave us some preliminary overviews of the work that they were doing at her organization. And we're so appreciative to have her back now virtually. Her name is Trish Riley. She is the Executive Director of the National Academy for State Health Policy. She has a lot of experience in state government, now mostly in Maine, and she's been working with state government agencies since her organization was founded. We're very appreciative that you're here, Trish. The Academy of State Health Policy is a nonpartisan forum of state government policymakers who are learning, leading, and implementing innovative solutions to health policy challenges. And she's going to share with us a couple of policy recommendations that they're working on. Thanks a lot, Trish.
Well, I'm really pleased to be here, and it's especially great to have heard Ira's great presentation. And I would just reiterate, price is the issue. And so we are very much engaged in models that will address that. Let me just do a bit of background here so that you can see there's been a lot of activity through the states. As you can see, virtually every state has proposed something. Since 2017, 48 states have enacted 160 laws. So lots of activities, and we've learned lots of lessons to inform this next round of models. In a snapshot, those lessons first and foremost are, no matter what you do in drug pricing, no matter how narrow and clearly defined your proposal is, no matter how broad and expansive it is, you will get significant pushback from the pharmaceutical industry and the supply chain, and you will likely end up in court. So that's the reality of this work. And I think what we did as a result of some of our experience over the last year, we have engaged some of the nation's greatest legal thinkers to help us frame these new models in ways that, should you go to court, you are most likely to succeed. So the other lessons learned are from primarily three models. Many states embrace the notion of transparency, unlocking the black box of drug pricing. They've learned a lot about what the kind of data that Ira just showed about what drives costs in the states. Very important, very significant to understand the pricing strategies, but not enough. Once you know, what do you do about it? 6 states have enacted drug importation from Canada. The federal government, that they pushed the federal government has finally, after many decades, issued rules to govern that initiative, but the rules are not flawless and need some significant work. It's still a good deal of heavy lifting for states to do importation. They're hard at it. There's some pushback from Canada. And one of the problems with importing drugs is that you can't, by law, import biologics. A number of states have looked at affordability boards, the notion of setting up like a public utilities commission on drug pricing, and set an upper payment limit for what a state payer would pay. In Maryland, they've taken the most significant action. They are up, they are implemented. It's a long process. In establishing that board, the governor has vetoed their funding. They hope to overcome that in this session. In Washington, a similar affordability review board was enacted, but the governor vetoed it. So that's where we are. Those are the lessons learned. And the key lesson here is that we clearly needed models that not only had good, solid legal grounding, but that were administratively easier and less costly. So those were the two primary issues that drove this next round of looking at price increases. Our first model is modeled in part by some work that's gone on in Massachusetts, the notion of creating a tax on unsupported price increases. We know that the Institute of Clinical and Economic Review, ICER, produces an annual report that identifies those drugs where their increases outpaced inflation by 2 times medical inflation. It's clearly a determination where these increases are not justified by clinical data. So that list exists. It's a short list. It's not every drug, but it's a starting place where states could take that list, carefully crafted, and use it to encourage manufacturers to meet the lower price or to pay a tax if they don't. So it's a tax structure administered primarily through the tax assessor, and it basically requires manufacturers to report on total sales and their prices in the state, and the assessor would then assess the fee. The penalty is 80% of the delta between last year's price and the unsupported price increase. Importantly, ICER's process is a significant one that engages pharma, other stakeholders, states. It identifies with states the key drivers to make sure that those lists are as compatible as they can be. It gives pharma the opportunity to come in and make its case to support a price increase. So it's a carefully independent and clinically driven analysis. Again, a shorter list, but an important one. And if we look at the results, here you see there's the list price, there's the increase, and there's the savings in millions. So clearly on this subset of drugs, and these are largely drugs that have significant utilization and significant price. They're not those tiny drugs that Ira talked about, but they could be. And this is what ICER proposes. So here you get the data from ICER that you can use. Importantly, ICER concluded that this subset of drugs increased pharmaceutical spending by $4.8 billion in excess costs over 2 years. So these are real dollars, real savings. We know that there are legal challenges when we get into this business. Importantly, we are not in any of these models setting prices. We are not going head to head with patent preemption. The patent laws obviously state that state price controls can't interfere with federal patent schemes that protect the ability of the industry to gain profit from their R&D, from their inventions. There was a DC law that effectively proposed to limit excess pricing in pharmaceuticals that was struck down in the Biotech Industry Organization v. DC. That we've used that court case to make sure that this law does not run afoul of patent protection. There are 3 ways it avoids that preemption. First is it is not solely directed to patented drugs. So any drug, patent or generic, would be subject to these taxes. Secondly, the DC law was on price. It said price cannot be excessive. This is not a price law. This is a price increase law. Patent holders, manufacturers are still able to set whatever price they want. It's just that if that price is determined to be unsupported by the evidence, that delta would be subject to a fine. And importantly, it's only 80% of the price increase that is the base for the fine, so that the company would still be profitable. So it's unlike the District of Columbia in that regard. Vagueness was an issue that was part of what struck down a Maryland price gouging bill, when it was unclear what an excessive price really was. It wasn't well defined. Here we have a very clear definition. It's the ICER analyses, well documented, publicly available, that constitute what makes up an unsupported price increase. And the biggie for states is the Dormant Commerce Clause. Every time the industry is confronted with a state initiative, they assert that anything that a state does to regulate prices affects their business in other states and thus triggers the Dormant Commerce Clause and is a violation thereof. Clearly, that requires a state to construct its legislation clearly around the individual state. And here in this unsupported price increase bill, the tax is only on units sold within the state, and the manufacturer must sell at least $250,000 worth of drugs a year in the state. So that, in a nutshell, is the tax assessment on unsupported price increases. Easy to administer, and the fines can help support any kind of administrative costs. They can also be used, as the state wishes, obviously, to assure that consumers are benefited, but it's a significant amount of money that could be generated. The challenge with this, and each one of these states have somewhat limited capacity to take on this issue. But the challenge here is that it speaks to price increases, but not launch prices. So the unintended consequence could, I suppose, be increases in launch prices. One doesn't know what the behavior of the industry would be. The next model goes directly to price and goes directly to both launch and price increases. And it would be establishing an international reference rate that would define what payers in a state pay for drugs. Again, importantly, we are not setting prices. Manufacturers can set whatever price they wish, but we will only pay a certain set amount for a core group of drugs. We know quite well that foreign countries pay a fraction of what we pay, and that rate setting is a very common approach to all the rest of healthcare. This is basically taking the notion that exists in the rest of healthcare and applying it to drugs. We know, for example, that hospitals have charge masters, but that's not what people pay for their hospital care. Like an auto dealer who has a list price for a car, but that's not what people pay. Here we're saying you can have drug manufacturers any list price you want, but this is what we will pay for 250 of the most costly drugs within our state. And we'll use Canadian prices as the benchmark for what that upper payment limit would be. It would work, and each state will make a determination about how it works and what the infrastructure is best suited for. But you have Marie, so of course I would go with the state insurance department. But it basically asks for collaboration between the Department of Insurance and the Board of Pharmacy, and uses a state employee health plan. Again, our goal was to make this as administratively simple and less costly as it could be. Looks at the state employee health plan to identify the 250 costliest drugs to that plan as a proxy for all commercial payment within the state. And we think it holds up. The Department of Insurance would determine the Canadian prices, compare, and those are publicly available, and we have a tool that can help you do that. And set an upper payment limit for those 250 drugs or any subset of drugs that you choose to do. Payers, it would be against the law for a payer to pay more than the limit for the drug. And as I was listening to Ira, I thought, maybe we need to be clear that hospitals would be one of those payers when we think about the medical drugs as well. Of course, states cannot impose regulation on ERISA plans, self-funded plans, so this invites them to participate voluntarily. It does exempt Medicaid because of the unique federal rules and waiver and rebate provisions that apply, and it has a protection in it for local pharmacies. So why Canada? Of course, it's a neighbor, we know it, their population, much like our population. But the real reason is their data is available publicly. Other countries are a little less transparent. And importantly, the Canadian government uses all those other countries to set its price. They look at a basket of drug prices from other developed nations, France, Japan, UK, many others, to determine the price. We then take that price that the Canadians have established, use it from 4 diverse provinces to give us some kind of breadth, And if those prices are not available in the provinces, there is also in Canada the Patented Medicines Price Review Board, and we could go to that source. We would use those sources or the US price if it's cheaper to set the upper limit. And importantly, there's been considerable discussion by President Trump of using Medicare as a most favored and and establish a Medicare rate around most favored nation. Vice President Biden has proposed a German model that would be a negotiated model, I think again around Medicare, but a state could enact an international pricing law that gave you flexibility to either use Canada or should Medicare create a similar program to reference it to Medicare. So it gives you some room. And somebody asked about the pricing, and here are some pretty compelling drug prices. And importantly, when you look at this, this is per unit. So, per unit, per pill, per syringe. And as you can see, really significant savings. And we do have a tool that can, should you want to take this on, help you use your state employee health drug spending and determine a savings there. So here too, the biotech versus DC case rears its ugly head. Here too, we have used our lawyers to craft a piece of legislation that we think is strong in that it doesn't limit to patented products. And unlike DC, it does not regulate the price. And it very strictly limits transactions to in-state. And we think that's clearly an interesting and important sort of initiative to just be very tight in the language. This bill has already been introduced in Pennsylvania. We've talked to a number of other states who are interested. I think we need to wait until the election to see where people fall and what might be next. Let me end there in hopes that there might be some questions. And I know it's late in a long Zoom day and you have a panel ahead. Just note that our drug pricing center supported by Arnold Ventures is available to help. We have a variety of tasks and tools. We've recently hired a lawyer, Drew Gatine, who presently is a legislator in Maine. He chairs the Appropriations Committee, was formerly Assistant Attorney General. He's been helping us draft these bills and is available to work with legislative drafters and provide any kind of technical assistance we can, and we would be more than happy to do so. With that, let me pause.
Thank you, Trish. There are a few questions that came in. I'm going to focus on the ones that are more on point. One is an observation. It says, via a multi-state initiative, we can, I believe, take aim at the price we are willing to pay for drugs. It will be a long process, though. Not taking no for an answer will get us there. We could address Medicaid, those incarcerated, state employees, if desired, and municipal employees, if desired. So I think that's more an observation than a question. The second one is a question, though.
Well, to that observation, I would. It is very appealing and very challenging. Often, multi-state initiatives like that require compacts, multi-state legislatures to agree. Important, worthy goal, but not an easy task.
So you'd recommend Rhode Island going alone?
I think you could talk to peers, but I think it might be worth going alone. It's just a long process unless you can find somebody on the same wavelength. And then elections sometimes change those things. But I think it's definitely possible to think of a multi-state organization.
Okay, thanks. There's a follow-up comment. We're not big enough to go alone. You think that's so? Is Rhode Island too small to go alone?
Well, in the provisions on the international pricing, we have penalties should a company withdraw from its drugs from the state, to a really serious set of fines and potential antitrust enforcement provisions. I think certainly Rhode Island is not too small to use the unsupported price index, available data. And I think the international pricing could be a big lift, but I think it's possible. And it may be that a smaller state may not capture the same kind of attention as a larger state, but we'll see.
Great, thanks. Here's a question. Whether in allowing ERISA plans to participate voluntarily one could tie other requirements in order to participate. For example, submission of claims into the APCD, following other fully insured requirements. If possible, could OHIC also require that there be either no or minimal charges from TPAs for that submission?
Oh, the Gobet case. Let me think about that. I think the challenge would be we could go head to head with Gobet. It is still a well, if it's part of their voluntary engagement. It's possible. Let me talk to our lawyers about that. Would it trigger the Gobet, or would it be part of a voluntary participation? It's an interesting idea. It might well work.
Okay, the next question is the ratio of prices just US to Canada mirrored in other medical prices, hospital charges, physician fees, or is the drug price problem an outlier?
That's a good question. I don't honestly know. I suspect given that US healthcare is by and large much more expensive than every other part of the country, it's for hospital services as well.
Okay, and last, what's the future of the 340B program?
Next question. 340B is a hot topic, and I think this administration tried to take it on. I think there is legitimate concern that it has been carried beyond its initial intent to assist safety net and other providers. In a world of consolidated healthcare, we see very large hospital systems taking advantage of 340B and not necessarily passing those savings on to consumers. So I think there is some legitimate reason to review the program, and I think it could be reviewed with the understanding that that review would be designed to protect the original intent of the 340B program.
Thanks, Trish. I'm sorry, one last question. Sorry if I missed it. PBMs across state lines, how would that work?
Yeah, I think the PBM in many respects, the PBM becomes, in the IPI, becomes arguably not necessary. One could think about a carve out. I'm sure the PBMs would not enjoy that, but you could carve out the subset of drugs and avoid triggering any kind of PBM activity.
Yeah, that's great. I'd like to introduce Dr. Peter Hollmann. Dr. Hollmann with University Medicine. He's affiliated with Brown, immediate past president of the Medical Society, just one of those people that somehow manages to have 50 hours in his day, member of the Cost Trend Steering Committee. Dr. Hollmann, thank you so much, and I'll turn it over to you and your esteemed panel.
Thanks a lot. And thanks a lot to Ms. Riley and Dr. Wilson for those great presentations. They were very informative. As we know, Ira summed it up very nicely. It's the price, stupid. And Ms. Riley told us a lot about the implications of trying to be successful in implementing these programs. We have as our panel three people. I'm very pleased and privileged to be part of the moderating this group. I'm going to introduce them alphabetically. Monica Osiello is Vice President of Legal Affairs and Policy and General Counsel of Blue Cross and Blue Shield of Rhode Island. She's been there since 2005, having come from Blue Cross and Blue Shield of Vermont. She gives legal counsel on a diversity of matters pertaining to Blue Cross and Blue Shield's business operation, ensuring the company's compliance with state and federal laws and regulation. She's her primary liaison with state regulators and leads the government relations efforts for the organization. She's also been an important and active participant in many of the task force initiatives of the Office of the Health Insurance Commissioner. I was privileged, or maybe she was a little unlucky, to work with me for 10 years of her duration at Blue Cross and Blue Shield of Rhode Island. Mr. Tony Klapsis is Vice President and Head of CVS Health Enterprise Strategy, which develops the long-term strategy for the overall business for CVS Pharmacy, CVS Caremark, and their transformation. Big job, a lot of activities. Beyond strategy, he's played a leading role in new growth opportunities, including entry into kidney care and dialysis, the acquisition of Aetna, creation of a nationwide COVID testing solution, and a clinical trial platform. He has a very interesting background. He's had 20 years of health experience in government, Wall Street, and for employers. And before joining CVS in 2015, he served as chief of staff for the CEO of Caesars Entertainment. So he's going to tell us what are the good bets as we go through these processes. He also was on the professional staff of the Senate Finance Committee when the ACA was drafted, had a strong background in the financing world, working at Lehman Brothers before they collapsed, Barclays Capital, and he started his career in the Massachusetts State Senate. And finally, Paul Larratt. Dr. Paul Larratt is the Dean and Professor of the University of Rhode Island College of Pharmacy. His research and teaching activities are focused on drug use and special populations, health policy, and health economics. He's also served as the founding coordinating dean of URI's Academic Health Collaborative from 2015 to 2019. Early in his career, he has a lot of direct experience on one of the last questions about PBMs. He was employed as Executive Vice President of MIM Health Plans, and where he was responsible for developing the operation of a pharmacy benefit management company that saw the growth from 3 million in gross revenues to over 300 million. Of course, this was a lifetime ago, ending in 1997. He was responsible for many, many activities in that organization. In 2010 to 2011, he served as a Congressional Health Policy Fellow in the United States Senate, engaged in developing healthcare and aging legislation and policy in the Finance Committee with chair of that committee, Senator Ron Wyden, a Democrat from Oregon. So you can see our folks on this panel have a broad breadth of experience in some of the many applications of these types of issues, whether it's implementation, politics, legislation, or policy. And I'm hoping that we can discuss a few of the issues. I think we need to hear whether some of the proposals seem to be clinically feasible, whether we think they are feasible in terms of consumer support, purchaser support, and political feasibility, and talk about some of the implementations that might need to be addressed. And it does seem that a pretty strong case has been made that if we are able to successfully implement these, there will be substantial cost savings. So I'm not going to probably be able to do quite as nice a job as the previous moderator did in having everybody address the same topic, but I know that there are lots of understanding of the topic by each one of our panelists. But I'd like to start out with Dr. Larratt. And just, could you tell us a little bit about whether there are multiple therapeutic alternatives in these classes of drugs that Dr. Wilson has shown us are the high cost drugs, and whether it's going to be clinically feasible to implement some of these programs?
I think probably the answer is yes to some of the categories that we're talking about, some of the disease states that we're talking about. As you know, these very high cost drugs, the monoclonals and such, they haven't been around all that long. So many of the really truly revolutionary products are still in their infancy. They're still patent protected to some extent, although there are quite a few alternatives such as biosimilars and other similar products coming aboard. I think it's going to depend upon those different categories of drugs and how they, how many competitor products are out there. For instance, in the hepatitis C area, it started out with, one product in a very successful product, and we were shocked by the cost of it. And within a couple of years, a number of different alternatives came out for this oral product, and slowly prices began to moderate. So I think it's feasible, but it depends on the therapeutic class and how many competitor products are out there.
Well, the next question that I had really has a lot to do with how the regulations apply in Rhode Island. So I'm interested in finding out just what percentage of our business is regulated by the Office of the Health Insurance Commissioner, and whether you think implementing some of these regulations would sort of help level the playing field competitively, or whether in fact we might see a lot of companies, even very small companies, through the use of reinsurance that comes into play very early in the number of costs per employee, go to a method where almost everybody is self-insured because they really don't like this new regulation, or they've been convinced that it's a bad idea. So we see a change in the market. So what impact do you think this might have in the insurance market? And do you think purchasers are willing to engage in this? So why don't I start out with one of the folks that sells insurance, and then I'll go to the next panelist who both has an insurance company and uses a lot of insurance as well for their large national employee network?
About 50% of the commercial market is self-insured, meaning that it's exempt from state regulation. If it's private companies providing coverage to their employees, we do have a significant portion of municipal and state self-funded plans, which would be not subject to, don't have the ERISA preemption, but also are not directly subject to state regulation, but generally follow what the state rules are as they're implemented. I really found Trish Riley's presentation fascinating, particularly the ICER, tying to ICER. I think that really has a lot of potential for us here in Rhode Island, and would love to explore that further. I saw that Senator DePalma is on the Zoom as well, and would note that he had also introduced earlier in the General Assembly session a legislation to essentially create an assessment, a tax that would help pay for high cost drugs. If you think of some of the particularly high cost drugs and where we're seeing, even beyond what Ira included in his presentation, these really new blockbuster drugs that treat a very small, unique population and have extremely large price tags. An example of that is probably not get the name right, but Zolgensma, which is a curative gene therapy for spinal muscular atrophy in children under the age of 2, literally a cure for babies suffering and born with that illness, is a $2 million cost for one curative dose of the medication. And that cost is something that is significant for any payer, whether that's Medicaid, whether that's a self-funded employer, whether it's an insurance company. You would have no reason to believe that your population is more likely per se to have a child born with that illness in your population. And so that cost can be catastrophic over time. Senator DePalma's legislation would have created an assessment on payers to, essentially raise funds to pay for that kind of medication. The state would procure the medication and negotiate with the manufacturers on a value-based payment structure to pay for those medications. And I think of Trish's proposal around tying to ICER and maybe having a tax on the differential in the price could help fund some of those medications as well and improve access. You may even see some of those funds being an opportunity for what we hear would be some inability to access more common drugs like insulin because of cost issues. So I really found that interesting. I thought it has a lot of potential for Rhode Island. I see a tie potentially to something like Senator DePalma's proposal, and I think there are things we should further explore for the state.
The governor has joined our call, and we all know what a great job she has been doing for the state through this crisis, but she is still very committed to the work that we're doing, and she's on the line. Governor, if you'd like to say a few words, please welcome.
So thank you, Marie, for allowing me to say hello to everybody. I wanted to thank you for your work. I hope you've had a productive morning and afternoon so far. The work that you're doing is, as Marie said, I've been preoccupied dealing with COVID and what that means, the health implications, the economic implications, the public safety implications. Having said all of that, this is still very important to me. This is still a top priority of mine. This is a big deal. I've been involved in it personally since we came up with the idea, helped raise some of the money philanthropically to get the structure going. And it was important for me to be with you even briefly to let you know this work is vital to the future health and economic prosperity of Rhode Island. And it is a top priority of mine specifically, and you have my support. Obviously, COVID has challenged us to think even more creatively about how we deliver healthcare in terms of in what communities, how we break down barriers, use of technology, telemedicine, necessity of mental health and covering mental health care. I mean, COVID's really brought to the forefront so many of the things that we have already been thinking about, but now with a new sense of urgency. The reason that this matters so much is because, you know, I feel like the Affordable Care Act, for all of its problems, has largely brought about access, and particularly in Rhode Island, okay? The way we are implementing the Affordable Care Act. We've done a pretty good job, not perfect, but access is pretty good here. We can't say the same about cost. Now, thankfully, we have Marie, who keeps us all in check, so that's important and nothing to sneeze at. But there's other ways to do it too. You know, it's not just through her stick or the velvet glove that she has. You know, there's some creative thinking that we can do together. And that's what this is all about and why I'm so excited about it. Because look, here's the reality. We have to pay for mental health. We have to pay for home care. We have to, you know, provide coverage. But we also have to keep costs down. And because if we don't, that's going to show up on somebody's premium bill that they can't afford because Rhode Islanders are struggling now more than ever. If we don't, it's going to show up all over the economy. It's going to burden small businesses. It's going to burden the average family. And so, you know, I think it feels like for 50 years, America has been trying to get the holy grail of lower cost, increased quality, and broad access. So we must be stubborn idealists if we're still at it. But it is the name of the game. And this, what you guys are doing, these cross-trend hearings, this is a big deal. We've never done it like this in Rhode Island. And the fact that everybody is in the room or on a Zoom committed to it is so exciting to me. And the seeds you're planting now should be felt a decade from now and in the years between now and a decade from now in like higher quality, lower cost, more innovation, decent premiums that people can afford and not overburdening of small businesses with their healthcare bills. So as you can tell, I'm excited. I wish I could have been with you all morning. And let's use the occasion of COVID to move this work further and faster than we might have otherwise. It would be the challenge that I put to all of you.
Thank you. Monica was a tough act to follow. I guess I got twice as hard now. Governor, it's nice to meet you and thank you for the words.
Thank you for everything CVS has done. CVS has been such a stand-up partner to the state of Rhode Island from day one through this and continues to be so. So take that up the chain. Say thank you.
I'll let Larry know. No, in all honesty, we spent a lot of time on testing, and you were early and almost first at it, right? And we're about to get to 4,800 stores nationwide where we're actually offering, you know, COVID testing. We've been building it over the last 3-4 months, you know, but we really started it here in Rhode Island, kind of built and proved the model out. And really excited about what we're able to do sort of across the country to increase access to testing. So thank you for your leadership there. On the drug front, Monica hit, I think, some of the points around, you know, the follow-on, some of the Me Too drugs and a little bit with ICER. I'd say from our perspective, you know, listen, if you're trying to control drug costs, one, we don't set the list price, right? So automatically that's a fundamental structural issue, right? When you think about pharma and drug pricing. When we think about Me Too, I think the ICER work is I think fascinating. They do fantastic work. I pretend to be a lawyer, so I might take a guess at some of the risk implications of that at Rutledge. We spent some time with ICER trying to roll out a voluntary product for employers, to be able to sort of use ICER standards around Me Too products. So, Monica mentioned Zolgensma. It's hard, though there's probably 3 or 4 different management techniques we've used with that kind of category of drugs, whether it's stop loss insurance, incremental sort of step payments to try and attack that as well. With ICER, it was interesting. Last year, we rolled out a program really trying to use ICER standards around Me Too products in non-breakthrough categories. And employers and patient groups, employers didn't really pick it up, right? We only had about 250,000, total enrollees. And there's also really strong pushback, I'd say, from patient groups as well, at really considering kind of that kind of link. That said, I think we learned some interesting things. It is effective when you can use tools like that. And part of the reason I think it didn't grow is in some of those Me Too non-breakthrough categories, the second and third manufacturer coming into market were actually starting to price within ICER guidelines. So there's certainly, I think, a lot of creative ways to think, not just from a full statutory to state or federal level, but really also creatively within our benefit programs and in the way employers actually choose what utilization tools they're going to manage, to really understand how we can start to drive a kind of change in behavior on the part of manufacturers as well.
Thanks very much. I should have started out by saying that part of the goal of the panel is to give advice to the whole committee that's going to be working on the cost trends in terms of activities that we can take. And I know in some of these things that we're talking about now are presentations by Trish Riley and Ira Wilson. So if they have want to add or jump in on anyone, please just go ahead. So your sense is that there was some market for a certain type of product amongst some of your employer groups. And one of the questions I had was on capping the payments, whether that would mean that those drugs would be available to folks and the price would be covered at the full contract that the insured would normally have, or whether there would be additional payments that the insured might have to pay because you were capped at a price that the insurance company paid, but the beneficiary might have to pay a differential on that, or whether the drugs would just not be available. So I was wondering whether people had a response to that. And I would include Dr. Larratt as well, because he's very involved in all this stuff. He has a strong policy background and was involved in PBM. So I think what I'll do is I'll ask him to go ahead and start out with that question.
These what Trisha's brought up already these are relatively new ideas, even though they're being tested out in other states. So I'm not sure we have the exact answer for you, because a number of different ways that the patient pays into this system have been discussed. And, I can count at least 4 or 5 ways. You mentioned several. So I think it's fairly early in the process, and I'm not sure that we have a great answer for you as far as, what would actually happen when this really hits in the real world. And maybe Tony has a different answer to that, but.
Let's put him on the spot.
Yes.
Get to mix it up a little bit. So Pete, your question is more if we went to full caps, what's the beneficiary impact? Or I want to make sure I'm.
Well, the recommendation, and Ms. Riley might be able to explain if I have misconceptions about it, is that you're capping the price through international reference pricing that a payer can pay. But the question is does that mean that the beneficiary gets the full effect of that? Or is there the potential that, that's how much the insurance company pays, but then the beneficiary might have to pay something else? And would you have to restructure your contracts with the insureds so that, so that they still have access to the drug?
It's a great question. A kind of uncharted territory, I think, for the most part. I mean, there's elements of incremental tax incentives, certainly in the Part D benefit as well, right? Where we try and, I think, through the federal legislation, sort of discourage sort of price increases from that perspective. You've seen some, versions of it. Again, not the exact version I think Trish was really kind of recommending, certainly on hyperinflationary products, where I think you see people willing to take, I think, kind of much more, dramatic action. You certainly haven't seen, I think, from payers or PBMs, certainly patient groups, ever willingness to completely shut a product out unless it is in a very kind of competitive category, right? So to me, those are kind of the bounds of the extremes or the existing kind of models. So here, I don't foresee any kind of a balance bill-like option where you would really try, then drop the excess, what's not covered on the part of the beneficiary. I can't imagine the kind of revolt, you would see if a payer or a PBM, or a government entity really tried to drive that kind of an impact at that level of a price. So I think folks, initial reaction would have to really get creative and really thinking through how to restructure contracts and potentially what something like that could mean.
I agree with Tony. The only other thing I wanted to add is on the other concept around the taxing of the difference, right? We did have in Rhode Island, we do have in Rhode Island a tax on opioids. And that has had, to some extent, a chilling effect on the availability of those drugs in Rhode Island because of the tax. And so we want to make sure that whatever we put in place, if we were to go down that path of, trying to tax on unreasonable price increases, that it doesn't stop the availability of those drugs for Rhode Islanders or cause some sort of runaround, for example, exporting out of the state to another state that might not have such a tax, so that the drug would still be available at that higher price there. So there are certainly things we would want to be thinking about and thoughtful about as we move into any of these ideas. And it to me raises one of the real issues here is it's really hard to address pharmacy costs through state policy. It's not necessarily, as we've seen, any easier to do it at the federal level, quite frankly, but certainly a national solution would be more ideal, just to avoid some of those surrounding issues and hopefully to address some of the litigation risks that Trish discussed. But all of these things, I think we should be exploring every opportunity we can to address this category differently than we have.
Yeah, I was particularly interested in experience with the opioid tax because I'm not sure exactly all the impacts that had. You mentioned a couple about availability of the product and also sort of manipulations to avoid the tax through importation. And I wasn't sure if other panel members had comments on that as a lesson learned as to how one can implement these and what seem to be at least the short-term implications of implementing such policies. So thank you for that. Tony and Paul?
I would just add just very quickly that, whenever you implement something like this, particularly at the state level, there's always the unintended consequences. There's always a reaction from the folks that you're changing the parameters on. So I think we see some of that at times, and it was alluded to just now. When one state has one type of policy and another state has another, there's an incentive for the folks that are affected to change their policies, change their approach to what's going on. So I think we have to be careful of these unintended consequences that might occur.
Yeah, I'm used to maybe legislating at the federal level on some of these things, and it's almost easier, right? Not to have to worry about some of those interstate impacts.
Yeah.
I will just say, I think these very same issues, I think, are going to be very resonant in the first half of next year, once we get past this election.
Trish, we asked you, what we were talking about was a tax in Rhode Island about opioids. So that's unfair unless you happen to have experience with it. But we were also talking about the impact on generally on drug availability and other things that might affect the consumer.
Yeah, the point, I would love to learn more about the impacts of the tax on opioids. A couple of other states have done it. We will definitely pursue that and figure out what's going on and see what we can avoid. The issue of a cost shift to consumers, the law would prohibit that. I think it's pretty clear that any payer would pay only the upper payment limit, and I think there's a prohibition of any kind of pass-through. And I definitely want to meet Senator DePalma. I don't think either of these bills would impact the move to self-funded plans because they are voluntary. They're not regulatory, and that impact and a self-funded plan would be able to access lower prices, which I think is important. I'm not sure. I was taking notes and I'm trying to see if I've missed anything.
Yeah, you have such great expertise, so we wanted to take advantage of that. Maybe you also might have some thoughts, but first I maybe would help to ask Monica and then Tony about how they foresee some of this going through the legislature. And I guess we even have legislators on the conference today, so you might have a comment to make through chat or through questions. But I know that there have been things such as copay cards where pharma basically could offset the prices to the consumer for a highly expensive drug by making it at the consumer out-of-pocket cost being extremely low, and then the payer actually has to pay much more for a therapeutic equivalent of another drug. And that hasn't even been prohibited in Rhode Island, or at least to my knowledge, it hasn't been at this state. And that seemed one potential solution to drive down drug costs, not necessarily on the highest cost drugs. But that didn't seem to have enough legs because it maybe appeared to be anti-consumer. I was wondering if Monica could tell us anything about her experience in talking about that kind of legislation.
Copay cards and coupons are a very interesting conundrum, and you're right. I mean, there's been conversation over the years about how to address the availability of these, and I think it is hard, right? Who doesn't like to get their extra bucks coupon in the mail and have 30% off at CVS and have their list of things they want to go and get. And so it's really hard to help legislators, policymakers, and consumers understand that coupons are harmful. They do drive up costs. They do continue what is already a pretty lackluster in the transparency department, consumer good. And so, there's been a lot of conversation over the years about coupons. My recollection is Massachusetts did have a ban on coupons. I believe that has since been repealed. We have tried to have conversations in the General Assembly. There have been coupon bills introduced here as well, less to prohibit them. But I mean, think about a coupon or a copay card that is expressly only available if you have insurance. And what you might think that is the motivation for offering a coupon or a copay card only to insured, really to an altruistic, beneficial to the consumer view? It doesn't feel like it. It feels like it's with the intent of driving a lack of transparency and increasing overall costs. And so actually we had worked with a member of the General Assembly, I cannot remember the sponsor at the time, to require that sure, let's make coupons available. They're good consumer tools, but let's make sure they're available to the population who needs them most, who don't carry health insurance and who really can't afford these drugs. Because if it's really about getting those drugs in the hands of the people who need it most, then it should be available most to the uninsured. I would just also add that on Medicare, coupons and copay cards are prohibited by law, so they're not available to Medicare consumers. There's a reason for that. And again, when you come back to it, and they on their face literally are only available to people who carry insurance. It feels like a cost driver. So I think there's some things we can do. I know there's a lot in the drug conversation. It always comes back to the United States being one of only 2 countries that allows direct to consumer advertising. I think that is part of it, right? When you see a star that Cyndi Lauper is on TV talking about the cure of her skin condition, you want that too. And so, that kind of advertising does drive consumer behavior and interest, and never informs the consumer of what the actual price is, either at the pharmacy counter or ultimately in their premium, or the availability of other lower cost, equally effective, perhaps with fewer side effect medications.
Thanks so much. I know we have to have time for closing remarks. If Ms. Ganim would like, we can either proceed to that, or we can give each of the panelists like one quick sentence about what they learned today that they think we ought to take action on.
Yeah, I got to tune into the legislative session. I think coming up is one of the main takeaways, I think, for me. Second, obviously, I think it reinforced the complexity of acting at the topic, right? And it's going to be active, like I said, federal and clearly across all states kind of coming up. And I think the nuance of where you can kind of leverage both legislation, regulation, and also employer choice, I think becomes really, really important. So I know it sounds like a number of bills that legislature will consider, but I think pairing that also sometimes with some management tools that we can use in existing channels and doing both, I think, simultaneously, I think could be a really interesting way to kind of move the ball forward. Beyond that, thank you. It's really been a pleasure to be with everybody today.
I'm just stepping back to Dr. Wilson's presentation. I was struck by, I guess, the application of that 80-20 rule that we always talk about, or 90-10 rule, where 80% of the costs are attributable to, maybe 20% of the patients that are out there, or 20% of the meds. I think that gives us a great opportunity to really focus on the folks that need, our help the most, and certainly focus on the quality of their care and the expense of their care. I think it makes much more manageable that it's a much smaller group of people than we might think it is.
I think I said enough.
We did a nice job. Thanks so much, everybody.
Thank you. It was great to be part of the panel. I appreciate the opportunity.
Wonderful. So I just want to conclude by thanking everyone who has participated, both in the participant group as well as those on the panels. We very much appreciate it. The discussion today will be taken to our meeting on Monday. Yes, steering committee members, we have a meeting on Monday. We will be taking everything we heard and hopefully formulating some recommendations for state action. So this has been incredibly helpful. I've gotten some positive feedback from people in the comments, and we appreciate everyone who's participated. Thank you so much. And thank you to Brown University for operating our technology today. Goodbye, and thank you.